Is my screen visible?
Yes, Darshan.
Okay, thank you. So, good evening, everyone. So, the topic for today is EOLC, brain death, and endocrine disorders. We are going to focus on most important things. Routinely asked things could be skipped. So, EOLC, the main topic that I've taken is principles of EOLC, but I have tried to cover other topics as well. Just because this might be one of the questions, like a sub question in a theory paper. It might be either in your final paper 3 or anything they can ask even in paper 2. Okay. So what exactly is palliative care? Anyone can feel free to unmute and talk. Okay. This is something that most of us are seeing being done routinely as compared to what it was 10 or 15 years ago, right? So what is palliative care? So WHO defines palliative care as an approach that improves the quality of life of patients, be it adults or children, and their families who are facing problems associated with life-threatening illnesses. The palliative care usually prevents and relieves suffering through the following things. That is, it helps in early identification, correct assessment and treatment of pain, recognition and alleviating other problems which might be either physical, psychosocial, or spiritual. Okay. So, what is the key components when you talk about this? It usually is associated with providing relief from pain and other distressing symptoms, affirms life and regards dying as a normal process. It intends neither to hasten nor to postpone death. It integrates psychological and spiritual aspects of patient care, which is very much necessary. Offers support system to help patients live an actively, independent life as much as possible. Offers support system to the family as well, which is more important. Uses a multidisciplinary team approach. It's mainly focused at delivery of quality of life. Okay. And it can be applicable earlier in the course of illness as well. Okay. So what does NHPCO, that is the National Hospice and Palliative Care Organization, define palliative care as? You can see few things which are repetitive. Okay. That is very important to notice. That is, palliative care is a patient and family centric care that optimizes quality of life. Usually, it is a continuum of illness wherein it involves addressing topics like physical health, intellectual health, emotional health, social and spiritual needs of the patient. Okay. The European Association of Palliative Care, or the EAPC, defines palliation as an active and total care of patients whose disease is not responsive to the curative treatment. So it mainly focuses as control of pain and other symptoms and the psychological, social, and spiritual problems, which is paramount for such patients. Okay. The American Academy of Hospice and Palliative Medicine also focuses on the similar backgrounds. So whatever I've highlighted in yellow and green is what you guys need to remember. Okay. So there is no universal definition as such, because there are multiple organizations which has come forward and given multiple definitions. So all of them have few things in common. One thing, it's a comprehensive approach. It involves both the patient and the family. It focuses on quality of life. It also focuses on non-medical issues like the physical, intellectual, emotional, social, and spiritual components of the person's outcome. So that is something that you need to remember. Okay. So is palliation and hospice the same? So I think so. You might have heard about a lot of people speaking about hospice care right now, right? It was not very common before, but right now, with the growing population and with the knowledge of people about palliation and cancer incidents going up, these things are coming more commonly, in the day-to-day practice. So is palliation and hospice the same? Okay. So if it's not the same, what are the differences? So basically, palliative care, the timing is it can begin at any time during the illness. Okay. Generally, hospice is initiated during the end period. That is usually when the life expectancy of the patient is usually less than or equal to 6 months. Okay. It's a rough figure. It's not an accurate estimate. Okay. The treatment goals in palliative care can include both curative and comfort care, whereas in hospice, it focuses on comfort care only. In hospice, there is no approach for curative treatment. Location, both palliation and hospice can be given in multiple locations, be it hospital, clinics, or home. For hospice, there are few facilities called as hospice care. So they are specifically for this. In NHS, they specifically have a multiple things. Few centers in Bangalore and other parts of the country also have a few centers which are specialized in hospice care. So they are going to come more, when this is being routinely advocated to the general public. So prognosis, there is no specific life expectancy required for palliative care. Usually, as I've already mentioned, in hospice, probably the life expectancy is very less, probably in months. Okay. Both the services provided in palliative care and hospice care usually involve pain management, symptom relief, and other support. Okay. But in hospice, they look at other support like psychological, spiritual support, etc. The care is usually a multidisciplinary approach. Okay. So both in palliation and hospice, but hospice is dedicated palliative teams which take care. Usually you don't have an MDR treatment approach as in palliative care, which you usually see in hospitals. Okay. In hospice is usually the palliative experts, probably those who run the show. Duration for palliation, it depends on the illness and what the stage of the patient is. Okay. But in hospice, probably the patient is going to stay for a quite shorter period. So, in general, from the understanding of what is the definition of palliation, the difference between hospice. So, whenever you take any patient for that matter, you start from screening. Okay, this is a beautiful image which you can take. Take an example of a patient who has come to your ICU or your hospital. You have diagnosed them with a certain illness. So, at that point of time, you got to know that it is a non curative illness, probably a terminal illness. So, you start screening and getting the diagnosis. So, once you get the diagnosis, you will try and start off with a curative care. But in the meanwhile, you will further proceed with your active disease directed therapy, which might become futile. Okay. And it might be non productive, and that patient might be pushed towards a palliation. That time, you might have to initiate the concept of palliative care. So you can see that sometimes it is in the beginning itself, it will be palliation when they have terminal illnesses with poor prognosis. But sometimes they will have a malignancy, then it would have, actually gone into remission, and then they would have relapsed. Correct. So those kind of patients, probably in the second half of the third half, they can come back, into a palliative scenario. So there will be a particular time in the course of illness of any patient wherein all goal-directed therapies for curative treatment or palliative treatment would become counterproductive or futile. So at that particular time, we have to start something called as end-of-life care. But does everything end there? At the time, the patient might benefit with a very good end-of-life care, and then the patient might pass away. Is our work done there? No. The whole concept of palliation is to be with the patient as well as the family till we have bereavement practices. Okay. Bereavement is something that was usually given after the death of an individual, mainly focused at the family. Okay. So we need to focus on these concepts for overall holistic approach to any patient. Okay. So what is end of life care? That is the next question we need to ask. According to WHO, care that helps all those with advanced progressive incurable illness to live a a very probably respected, dignified life till they die is called as end of life care. Okay. So NHS defines end of life care as care and support of the people who are nearing the end of their life, and it is an important part of palliative care. NICE also defines it in a similar way, telling that it is care provided during the last part of person's life, typically in a year before the death. Okay. So what are the core components of EOLC? So you might get a question as what are the core components of end of life care? So if the question is core components, these are the headings that you might have to answer them under. They are physical support, emotional support, social support, spiritual support, and practical support. So in particular, what is physical support or physical care? It involves pain management, symptom control. When I say about symptom control, it depends on the type of malignancy. If the patient has some lung malignancy, probably requirement of oxygen. If the patient has nausea and vomiting secondary to chemotherapy, if excessive secretions are present, okay, or if they have an ileus, all of this comes under symptom control. It also involves personal care, comfort measures, and medication management. In medication management, it involves both curative and palliative treatment. Okay. Nutrition is also something that has to be aptly addressed throughout the process of end of life care. Probably pain management, symptom control, and nutrition forms the pillars of EOLC. This is what it is mandatory to be continued throughout the process of end of life care. Coming to emotional support, it usually involves counseling both the patient as well as the family. It involves anxiety management, depression screening, coping strategies, emotional validation. Okay. So when I speak about depression screening, coping strategies, and emotional validation, here the multidisciplinary approach comes into picture. Along with the palliative team, probably you might have to involve a psychologist or a psychiatrist to speak to both the family as well as the patient so as to help them cope up with the emotional trauma that they are going on. Okay. Coming to social support, it involves family involvement, communication facilitation, resource coordination, practical assistance, legacy work. Okay, so what I mean by these things usually is family involvement and communication makes the implementation of end of life care very easy. Okay, if you are at loggerheads with the family, probably we can never initiate a end of life care. It is always in consensus with the family. It's always a shared decision. So that is what we need to understand. Okay, practical assistance and legacy work is something that we need to consider about the patient's issues. Okay, probably it might be any physical support they need or any other kind of support which is necessary to transfer the patient to a probable hospice or a home-based care. Okay, at that particular time, you might have to support the family regarding probably bed assistance or probably the use of oxygen concentrators, etc. So these are practical assistances that has to be spoken about. Along with this, resource coordination also becomes important. Resource coordination involves factors like a care nurse or or a person who is going to be with the patient and bridge the gap between the hospital and the home. Okay, these are something that needs to be addressed in social support. Coming to spiritual care, it involves religious support, existential concerns, cultural practices, and meaning making, along with ritual observances. So, spiritual, I mean, the names itself make a lot of understanding there. So, whatever usually happens is at this point of time, when the patient ends up in a terminal illness, existential questions come into matter. Questions like, why me? Okay, and how long? All of this matters to them. At that particular time, probably spiritual support helps in. There are a lot of ways which spiritual supports have been, looked into, and multiple studies have been done in palliative medicine. There are certain things like the palliative department gets involved with pastoral care settings in predominantly Christian based hospitals, or else even in other corporate hospitals they have many religious people coming in and providing some spiritual care or uh, you know uh, spiritual support which they give in the hospital itself. Okay, so these things are something that needs to be considered. Ritual observances is anything which the patient wants at that particular time. Okay, if any patient wants to keep an idol next to them or if want to practice something else, they should be allowed to do so. Okay. So coming to practical support, advanced care planning, legal matters, especially with the current scenario, with the government itself considering the initiation and implementation of EOLC being a little like a double-edged sword, these things matter. If there is some legal matter which needs to be sorted out before the patient passes away, those things have to be helped across. So there are a specific set of guidelines which have come in from the position statements. You guys have to read that statement. It is already provided in the article section. Okay. So try and read those things so that you'll have some basic idea about what has to be done for practical support. Okay. Bereavement support, financial concerns, and funeral planning is something that can be addressed probably as an institutional protocol. Okay. This is something that you cannot do per se as a individual, but this has to happen as a protocolized way from the hospital. Okay. Care coordination is something that involves all the other components of EOLC that I've mentioned. It starts initially from the physical, component till the practical support. Okay, all these things, there should be a care manager who has to take in consideration, and then these have to be coordinated with all the people who are involved with the patient, probably from the treating team to the palliative team to the physical medical rehabilitation team and the spiritual support team. All of these things have to be coordinated well so that there is no confusion when EOLC is being continued. What are the key principles? So we spoke about the concept. Okay, so in this, what are the key principles? The key principles of EOLC are: it's a person centered or the patient centered care. It involves pain and symptom management. It involves communication, holistic approach, quality of life, family support, multidisciplinary team approach, ethical practice, and access to care. So this might be one of your questions. Okay, you need to remember under the following headings. Okay, so what is patient-centered care? It is respecting the patient's autonomy and preferences, maintaining the dignity throughout the care, individualizing care plans based on personal, cultural, and religious values, and honoring advanced directives. Okay, advanced directives are being introduced more so common compared to before. Okay, so these things have to be planned well in advanced. Next thing about principles is the pain and symptom management. You can use the WHO ladder of pain management for all the patients. Most important thing is they should be pain free. Okay, the dying in dignity involves the patient should not suffer. That is the most important thing when we initiate EOLC. Other issues that is associated is psychological distress that has to be addressed. Emotional support has to be given. And if at all there is anticipated problems because of pain management, that has to be preemptively looked into and addressed. Communications, it has to be a very clear, honest discussion about the prognosis. There should be no ambiguity when you're initiating end of life care. Okay. It should involve family members who are appropriate and the closed family circle. Regular update regarding the condition as and when it changes is necessary. You should be culturally sensitive in all interactions. Okay, supporting information regarding decision making should be given. Okay, whenever possible. Probably, if you have done a scan which shows progression of disease. Okay, if you're saying that the patient is going upon organ or life sustaining support, probably these things have to be given to the family so that they can make a better decision at that particular time, because it's an informed decision at that particular time. What is holistic approach? It means addressing every component of health, that is physical, emotional, social, and spiritual. It is usually focused both at the patient and the family. Psychological counseling is necessary because this is a traumatizing event to any person in the family and the patient. So both needs to receive psychological counseling. It should never be hurried on. These things will take time. Probably you have to give them the time that is necessary. Okay. So quality of life is usually focused on comfort rather than cure at that particular time. Maintaining function is apt and necessary wherein when possible. If the patient is able to move and mobilize out of bed, it's better to get them out of bed and moving. Okay, it's not necessary that they have to be lying down in a room and always, being fed or being treated like they are critically ill. No, that should not be the focus. Independence should be respected. Okay, that is what is necessary. Supporting and meaningful activities should be encouraged, and family interactions should be encouraged as in when possible. Okay, family support includes family care, involving the family in the care planning. Okay, this usually makes the family more intertwined with decision making. It also helps them get involved in a process and getting acclimatized to the end of life concept. Okay, so probably the shock of loss of someone would come down if the family starts involving the patient management as early as possible. So bereavement support is something that is necessary, that has to be given. As usually, most of the places, what happens is, and the patient is terminally ill, the patient passes away, and the family is left over there. This becomes even more important in cases like brain death, etc., wherein the patient would have become an organ donor, but if you have not spoken to the family after organ donation, it becomes futile to have spoken in length about organ donation and having not seen to the family and the person who actually did such a great job. So these things become very much necessary. So usually bereavement is something that we do after the death of a particular individual. Okay. So multidisciplinary team becomes necessary, and it's one of the initiating factors, and the first founding factors in start of EOLC. That is, whenever you have the primary board, usually they have to come into consensus. The treating team should come into a consensus that all possible treatment has been done, and rest the further treatment would not have a good prognosis. You should have a regular communication between all the factors that are involved of the faculties. Close role, the role definition should be clear. Comprehensive care planning should be given to the family after discussion. Ethical practice is very important in end of life care. I'll be talking about this in detail. Usually, the most important thing is the patient wishes should be taken into consideration. Confidentiality should be maintained, like in any medical case. Advanced directives, if they are present, probably it has to be implemented at the earliest. Ethical dilemmas should be dealt with transparency. Patient and the family should have access to care at all times. Okay, every possible services that are necessary should be given to them, from pain management to spiritual practices to any other practical support that has been available should be told to them, made sure that they are aware of such things and they have to have access to such things. Okay, so we have to coordinate with the family at each level of care, and whatever setting possible is comfortable for the family, that has to be given. So what is that access to care is, it need not be told that the patient should be in the hospital for the initiation and completion of end of life care. It is possible for us to give access of care, if possible, at their home itself, or in we can have someone visiting them in hospice. Okay, so this is something which is dealt with access to care. So this is few of the things that come into picture about end of life care, that is the principles. Okay, so you need to know principles involve person centered care, pain and symptom management, communication, holistic approach, quality of life, family support, MDR approach, ethical practice, and access to care. Okay, hope I'm clear. I know it is quite monotonous. Please, I apologize for that. But unfortunately, these are dry topics which will fetch you marks. So if you guys are feeling it is boring, free, unmute and ask any question so that I'll be able to answer. Any questions? Okay. So coming to setting of EOLC. Okay. I told you it can be in a hospital, home, or any hospice, correct? It can be in any of these places. What you usually have to know is, if you are in a hospital, you have all the facilities which are available from physicians to nurses to technicians, probably physiotherapists, etc. So that wouldn't be the problem. So the problem would arise if they're going to hospice, a care home, or their home, right? If they're going to any of these places, you need to give them an understanding of what facilities needs to be arranged in that particular place before you transport these patients there. Okay, so if they're going home, you should talk about community nursing. If your hospital is providing that, talk about family support, give them your emergency helpline numbers. If the patient is on oxygen, probably you have to talk about equipment provision. You have to speak to them about medication management, which might be for symptom relief. You should also talk to them about emergency planning. If at all the patient deteriorates quickly, what has to be done? Those things have to be mentioned to them. Similar things have to be also given in care home. Okay. So if these two things are more or less similar, in hospice, we almost know that the patient is in the terminal part of the illness. So what we usually focus there is the spiritual and family support. Specialized care regarding the end of life practices should be given to them. Bereavement support should be provided. And comfort is the main focus in hospice. Okay. So what are the infrastructural goals that are required, or the requirements that is present in end of life care provisions? Okay, this is one of the articles which were published almost 10 years ago. It's a decade since it's come, and it's a beautiful article in IGCCN. So it was one of the joint position statements which was given prior to the one which is already given in 2024. Okay, in that it very clearly states you should have a policy which actually comprises of a hospital policy elaborating on the plan of palliation. It should involve awareness and implementation. Okay. It should provide the understanding about the staffing and the resources that are necessary. Education and training of both the doctors and staff involved in palliation or end of life practices should be present. Documentation is very, very important. It is probably the sole important thing for us in palliation to prevent any litigation. The most important hurdle that all of the people involved in palliative treatment they are facing currently is the legal issues. So because of that, documentation becomes very mandatory. So you should have a clear end of life care pathway. I'll be discussing about that in the further slides. Standardized definitions of withholding, withdrawing of life support should be given. As and when possible, you should have a patient information sheet or a leaflet which can be provided to the family so that they can read and understand and educate themselves about end of life care. Okay. A specialized support, like I have mentioned previously, also should be in picture. So these are the infrastructural requirements for the initiation or implementation of good end of life care policy, space and staffing, education, documentation, and special support. Okay. So when we have done all of this, like in any ICU phenomenon, we have quality indicators even for end of life care. So physical quality indicators indicate pain control, symptom management, comfort level, personal care, and environmental comfort. The psychological quality indicators include anxiety levels, depression management, emotional support, and family coping with spiritual practices. The social indicators indicate, the thing involved in them are family satisfaction, communication quality, resource access, and support systems. You can have a audit which can happen in a periodic fashion to know whether these indicators are met in a timely manner. Okay. So coming to the next important thing, which is also a question which has been asked previously, what are the ethical principles of end of life care? I think so this everyone knows. No, please unmute and answer. How many ethical principles are there? Guys, you guys are going for exam. I think so ethical principles you have to tell.
Four. Five.
Very good. Okay. Dr. Paritosh, please unmute and yeah, speak. Who, anyone? 4, is it?
Autonomy.
Yes, good.
This. एक मिनट sir.
No, don't worry.
Beneficence,
Beneficent.
non-maleficence,
Beneficence, non-maleficence,
Very good, Dilip. Yeah, very good.
and last one is
Last one is. So you guys told about autonomy, right? So I just want to tell you there are not 4. There is a 5th one involved. Okay, I'll
fifth.
just speak
Yes,
to you.
the fifth.
Okay.
No?
Yes. So autonomy is the patient's autonomy. It determines the patient's self-determination, gives the patient the right to make informed decisions. At this particular time, he can also give advanced directives and informed consent, and you have to respect the patient's personal choice. Okay, that is very much mandatory in autonomy. The patient can tell that, okay, I do not want a certain thing. And by law, it is said that we can not do it. Okay. What is beneficence? It is acting in with the actions which are promoting patient's best interests. If the patient at any point of time becomes incapacitated to take a decision, we as medical fraternity, with the proxy that is the family, can do certain actions which is in the benefit of the patient. Okay. It is usually for maximizing potential benefits, minimizing harm, to have a positive intervention, improving the quality of life of that patient. Okay. So usually they will ask you to explain under certain headings. Okay. So you can talk about when the patient is intubated, Okay, if the patient requires something like a dialysis, the patient might not have thought about dialysis. Probably doing dialysis would help him in the long run. So that time, if you're taking it, it is for the benefit of the patient, right? So that comes under the legal ethical principle of beneficence. Okay, you autonomy for any decision. Probably if the patient is awake, he can tell, I do not want to get onto a ventilator if I'm very sick. Okay, that is addressing the patient's autonomy at that particular time. Okay, so probably you might have to respect that particular thing. So what is non-maleficence? It comes under the basic thing of any medical practice, that is primum non nocere, do no harm. Okay, so avoiding unnecessary suffering, preventing medical complications, proportionate medical interventions, not to go overhead and do something that is not going to have any impact in the long run, and minimizing invasive procedures as much as possible. The last one is social justice, which most of you forgot to tell, right? In social justice, it is about fair distribution of care, equal access to all resources. It is an indiscriminate care that you need to give, and you have to give equitable treatment. Okay. So, whenever we speak about social justice, it is about giving the patient uh, uh, in case the best example I would say this particular thing is uh, equal access to resources, right? When we had the pandemic, we had people at the age of 80, 90 coming to us for a requirement of a ventilator, and we have 10, 20 years old individuals coming with severe ARDS. So at that particular time, in the principle of social justice, we can turn down a patient who is aged and probably having a lesser lifespan to accommodate for a younger individual with a better quality of life in the long run. So at that particular time, it is not illegal or no, it is not unfair. It is only in the principle of social justice that you have taken a decision to give the bed to a younger age group individual, probably having a better chance of survival rather than an older individual with the multiple comorbidities who might have a lesser lifespan. Here, you're looking at the better utilization of healthcare. Okay, this is very rarely seen, but it is something that should not cause harm to us. Along with these four ethical principles, there's the most important thing, which is necessary, that is dignity. Okay, dignity of care is which is usually missed in the ethical principles. It involves preserving human worth, respecting the individuals, maintaining the privacy of the patient. Emotional and cultural sensitivity has to be looked into and addressed. Okay, this is the fifth important ethical principle. Okay, this is usually taken into consideration. Previously, whenever you used to get a question, it used to be under the headings of autonomy, beneficence, non-maleficence, and social justice. But the recent one, which has come into this thing, they have also spoken about dignity. Okay, so what is doctrine of double effect? Can anyone speak up by unmuting? Okay. So in non-maleficence, usually what happens? Usually you try to do something for the good of the patient, but it can have an ill effect, right? Like for a simple example, you take any antibiotic or you take anything, any drug for that matter. You usually give it to the patient for the betterment, probably to treat sepsis, but most of the antibiotics do have some amount of adverse reactions. So that is something which is unintended, and you didn't primarily have that intention, right? So that constitutes to something called as doctrine of double effect. Okay, it is an ethical principle that addresses situations where an action intended to do good may also cause harm. Okay, the core principle of doctrine of double effect is that harm can be morally permissible if the nature of the act is good or morally neutral in itself, the agent's intention, that is the treating physician, his aim is good, I'm sorry, that the good effect outweighs the bad effect in circumstances significant enough to warrant causing harm. Okay, is it clear right now? I think so. If I give an example, it'll be better. Okay, so let's take an example. When we are thinking about pain management in terminal illness, the good effect is relieving same pain with morphine, right? Similarly, we all know morphine given at certain doses can cause respiratory depression that might hasten death. Under the doctrine of double effect policy, the ethical principle will remain that you are non-maleficent. The primary intention was to treat pain, but in the act of doing that, if the patient has a respiratory depression and passes away, it is not going to be legally sound. I mean, it's not going to be, you're not going to be held responsible because you are trying to do that to help the patient get relieved of pain. Okay. These things come into picture only in end of life care. Giving overdose of morphine for any other patient in a post-operative setting is negligence. Okay, that has to be taken into consideration. This is something that we need to understand clearly. Okay, post-operative pain management, if morphine goes into an overdose state and leads to respiratory depression, which is not treated properly, that is negligence. Okay. So important considerations is distinguishing between intended or and merely foreseen side effects. It has to involve careful weighing of the proportionality of the problem. It should consider alternatives anywhere if it is possible. Okay, if any other mode of delivery of any particular thing is present, you have to consider those. Usually, the less harmful ones have to be considered. Okay, is it clear? Okay. Coming to the approach, all end-of-life care practices should have an informed consent. It should be having a comprehensive information. It should be making sure that if the patient's going to understand that, that is the patient's capacity, understanding capacity has to be taken into consideration. Family needs to be involved. Clear, communication has to be given to the family, and it has to be documented. Decision-making capacity should be understood. We have to make sure that the patient is sound mentally to give a decision and a consent. Okay, the competency has to be ascertained. Cognitive evaluation should be taken into picture. Surrogate decision markers can be taken into consideration if the patient is not mentally sound. That is someone with like a proxy. Anywhere if the patient has an advanced medical directive giving legal guardianship to someone else, they can get involved in decision making policies. Okay. Ethical considering consultation can be done wherein you have an issue wherein the next of kin or there is no advance directive or there is a confusion which is present at that particular time. Okay, that time you can have an ethical consulting done and then you can decide on who is going to be the decision making authority. Coming to withdrawal and withholding treatment, patient preferences, that is the autonomy, takes precedence. Medical futility is something that needs to be considered. Okay, there is one important thing I need to speak about. Whenever you're talking or giving counseling to the family relatives about end of life care practices, the term futility is more or less better when doctors are communicating to each other. Okay, when the communication is between the doctor and the family, the term like futility and etc. would not be good. Probably it should be in simple English, and terms like non-beneficial or something like that has to be considered. Okay, something that they are able to understand, and it should not give a understanding that okay, whatever is done so far is also futile, okay, or unnecessary. So those questions should not arise at that particular time. Important thing is quality of life assessment, ethical review, and family consultation. Pain management, like in any other concept of palliation and end of life care or hospice, has to be at the maximum amount. Okay, regular reassessment has to be done, and whatever breakthrough pain management that is necessary should be considered. Nutrition, hydration, and the route of nutrition at delivery, all of this has to be addressed because this is something that has to be continued in both palliation, end of life care, as well as hospice. Okay, so usually better coordination with the family or the care nurse involved is what is mandatory when the patient has been initiated on end of life care plan. Advanced care planning like documentation, legal issues, updating the family or the healthcare proxy becomes necessary. Cultural considerations also should be taken into picture. Okay, and I mean by cultural considerations, it is whether it's religious beliefs or the patient's personal belief, both have to be taken into consideration. Okay, so in whole, if you have a patient who is with terminal illness, the steps of end of life care are under these headings. Okay. Firstly, ask yourself when to initiate, whom to initiate. Okay. Is terminal illness there at the patient? Is all curative treatment going to be non-beneficial for that patient? If these questions are clear, and if you as the treating physician and the other involved faculty, probably the nephrologist, the neurologist, or the neurosurgeon involved, feel that okay, further life would be probably futile or it will be counterproductive, then you can think of initiating end of life care. Assess the physical symptoms, presence of any distress, uh, any other communication that is needed. Find out where the plan of care can be given, whether it's hospital or in hospice or at home. All of this has to be communicated, documented, and consents have to be taken. Any other help which is required, be it with devices, with medications or care requirements, have to be informed to the family. And you should also provide helpline numbers so that they can reach out to the people in the hospital or in the palliative department for certain doubts if anything arises. Always have a round the clock or whenever possible reassessment of these patients in terms of symptom control, pain management, etc. At along with these, most importantly, psychosocial issues have to be addressed. Emotional support has to be continued. Okay. Along with this, you have to reflect about your care practices at each time. Find out if there are any gaps in the care at your pathway which you have started in your hospital. Is there anything that you can do better than what is already going on? So constant reflection would help in better outcomes, and mindful practices can be implemented. So coming to the next concept, that is dying with dignity. There are multiple things that you need to know, but this is one of the things I picked up from the article that have been, showing from before. The components of good death involve, proper pain and symptom management, involves clear decision making, preparation of death both to the patient as well as the family, completion of a lot of issues, be it legal issues, family issues, all of this. Probably if the patient has some wishes that he needs to complete, all of that has to be taken care of. Other issues, if the patient wants to have be an organ donor, something like that, that has to be addressed at that particular time. Along with this, the affirmation of the patient becomes necessary. Okay, what I mean by that is it involves affirming the patient as a unique person, okay, who is having a disease, but understand that it is at a limitation. Okay, and his values and his preferences should be taken into consideration. So these are components of good death. Okay, so please go through this again if you feel that it is quite quick. Okay, see, these are more or less theoretical, and these are going to require repetitive reading for you to understand in total. Okay, the recall is going to be based on how you practice on a day-to-day practice. So when you have a patient with end of life care, just notice what you do and recall that. Okay, just imagine that you have a patient with terminal CA and you're giving end of life care, and what you do in your routine care. If you write that down, probably that will give you 90% of whatever I've already spoken about. Coming to what is hospice care, this is a few of the final slides. Okay, hospice, as I've told you, is usually given in the end of the patient's life, probably at the point wherein curative treatment has been stopped. The whole thing is about physical, emotional, and social and spiritual needs of the patient. It's for more or less the comfort of the patient, and it involves the quality of life at focus. It is more importantly a family-centric approach, and it should look at death as a natural process. Okay, it should not be looking at it as a suffering, usually given at the terminal part of the illness. Okay, physician certification is necessary when you're doing this. Uh, in India, hospice cares are slowly coming up. Okay, so right now it will start coming up. So documentation is something that I've been stressing on and going to stress on later as well. So core services involve both medical, nursing, social services, and spiritual care, like in end of life care. Along with this, the most important thing is bereavement support. Okay, so usually in hospices, the patients usually pass away. So pre-death counseling becomes necessary so that the family can take in the shock of a loss of an individual. Along with that, grief support groups, etc., should be given to the patient. It's a good practice to follow up on these families after the patient has passed away as well. Probably there might be a certain doubts which might be taunting them, and they might end up in a state of post-traumatic stress disorder, etc. Probably helping them cope up with some psychological support with your psychologist or a psychiatrist would help them have a better outcome. Okay. What There are few definitions that I need you to understand, because these might be the questions that might be asked in exam. What is withdrawal of life support? What is withholding of life support? It's very straightforward. Withdrawal is you've already have a patient on a particular support system, be it ventilation, dialysis, or anything like that. At that particular time, if it's in the patient's best interest to stop or discontinue that treatment, it is called as withdrawal. Okay. The whole thing is the patient's dignity should not be lost. Okay. The following conditions must apply when you're initiating withdrawal. The patient usually should have been declared as brain death as per the Transplantation of Human Organs Act. Okay. Medical prognostication, considering the final outcomes, if at all any aggressive treatment has been given and it is to be poor, has to be established. Surrogate documentation about informed refusal or advance directives have to be present, okay, at that particular time. So compliance with procedure prescribed by the Honorable Supreme Court, I will be mentioning about this in the next slide, that has to also be taken care of. Withholding life support is something that you are not going to initiate itself. Probably putting a patient on dialysis, on ECMO, or on ventilation whenever it is necessary, understanding that the overall outcome is just going to prolong suffering and there is no going to be good outcomes in the long run. That is called as withholding. DNAR and AMDs are something that is quite straightforward. Do not resuscitate is something that is still in the loops and the current guidelines provided by the expert consensus position statement by the IAPC. Okay, this is something where active CPR is not given when the patient has been, given an advance directive not to resuscitate the patient. Okay. We already have to know one thing. Usually it is given in terminal illness patients wherein end of life care has been initiated or hospice has been initiated. Advance medical directive is a written declaration made by an individual with decision-making capacity, documenting as to how they would like to be medically treated or not treated when they lose their capacity to take decisions. Okay. This is something that you need to understand. Okay. It's a written declaration made by the person wherein they have lost the decision-making capacity. At that particular time, they would have made this directive when they were mentally sound. Okay. This is something that I want you to understand. So this is a recent position statement by the ISCCM in collaboration with the Indian Association of Palliative Care. Okay. This is with much deliberation with the Supreme Court, with multiple hearings over a period of time. Okay. So the final pathway for initiation has been given in this particular statement. It was given in Feb 2024. Okay. So usually it consists of two important things. That is the primary medical board and the secondary medical board. Previously, the requirement for subject expert was probably more than 15 years, 18 years, if I'm not wrong. Okay. So that has been reduced to more than 5 years. The primary medical board is usually from the hospital. These people are doctors who are directly involved with the care of the patient. Usually, it is the a multidisciplinary team which is usually involved in the care of the patient. Secondary medical board, one important thing you have to remember, it consists of one registered medical practitioner nominated by the CMO. The CMO is usually the one who has been appointed by the state government. Okay. Usually that has to be also informed to the court as well. Along with this RMP nominated by the chief medical officer, there can be two other subjects expert who are having an experience in that particular field for more than 5 years. These two subject experts need not be from the same hospital. There can be people from other hospitals as well if they don't have the adequate provisions. Okay. So the most important thing is people who comprise of the secondary medical board should not be a part of primary medical board. Okay, this is something that has to be considered. And all of this, sometimes if there is a discrepancy, there should be an ethics committee which is supposed to be there in the hospital, because if at all there is a discrepancy or something which is not coming into an understanding by the both parties, the clinical ethics committee can review this before further proceeding for any legal actions. Okay. So whenever you're thinking of giving an end of life care, whatever usually is done is the primary medical board passes it on to the secondary medical board, telling that further treatment would be futile. If the secondary medical board feels that, yeah, the decision of the primary medical board is correct, then you can implement probably withdrawal of life support or withholding of life support and end of life care, followed by grief and bereavement. Okay. If at all the secondary medical board feels that it is not in consensus with the primary medical board, you can take an expert opinion at that particular time. Okay. So usually the time between the primary medical board and the secondary medical board, as per the latest guidelines, is 48 hours. That is from the time of initiation of end of life care by the primary medical board, 48 hours have to be given to the secondary medical board. And within 48 hours, the secondary medical board has to come back to the primary medical board telling that your decision is right or wrong. Okay. If at all the decision by the expert panel comes not in favor of the primary medical board, either the primary medical board or the family has the right to approach the district magistrate, the high court. Okay. So they can go to the high court to review this matter, and the high court will further nominate a district magistrate to take a decision about such things. Okay. And then further decision about implementation of end of life care can be done. Okay. I hope I'm clear about that. If the secondary medical board is not in consensus with the primary medical board, the primary medical board, the hospital, or the family are free to go approach the clinical ethics committee. After that, they can take it to the high court, and the high court will direct a judicial magistrate to check into this, or the high court itself can listen to this and give an appeal. And after that, you can inform the judicial magistrate and then go ahead. Okay. In both the places, whenever you're doing end of life care, that is both primary medical board, secondary medical board gives go ahead, you have to just put a word to the district magistrate that you're initiating end of life care and then go ahead with it. You need not wait for a reply from the district magistrate about implementation. The whole thing is about intimation to the magistrate. That's it. Okay. So these are the references. I know it is quite theoretical and too dry. If there are any questions that you guys have, any doubts, you can feel free to ask. Otherwise, I'll start with the next thing, that is breaking bad news, which is more or less quite straightforward. Any doubts? Okay. Is my screen visible?
Yes, Darshan.
Okay. Coming to communication during end of life care. So I know breaking bad news is one of the common questions they ask, but types of communication is also the question that we are anticipating. You guys need to know there are a few terminologies that are necessary. That is, one is verbal communication, one is non-verbal communication, and the other one is written communication. So these are the three broad headings under which you have to answer if a question about types of communication comes into question. Okay. One is this way, that is verbal, non-verbal, and written. Okay. That the other one will be interpersonal communication, that is between doctors and doctors, that is between intensivist and probably a nephrologist, intensivist and a neurosurgeon, etc. Or it can be between doctors and nurses. Okay, or else it can be communication between doctors and family. Okay, so these are the other types of communication, that is interpersonal communications also come into a type of communication. So in verbal communication, we need to know that is a direct conversation, usually involves formal discussions. It can involve in telephonic consultations and multidisciplinary rounds. Non-verbal communication is usually based on facial expressions, body language, eye contact, okay, physical distances and postures. Written communication involves medical notes, patient charts, progress reports, consent forms, and discharge summaries, along with care plans. Okay, so this is very important. What usually happens is we always consider like, okay, I've spoken to the relatives, done something. Probably non-verbal communication at that particular time, if it is not correct, would be taken in a different way. Okay, posture, gestures, and facial expressions carry a lot of weightage in communication as well. Okay. Other type of communication are electronic communications, interprofessional communications like I've already spoken about. It can be during handover, multidisciplinary meetings, case conferences, collaborative care, etc. Family, especially involving breaking the bad news, prognostication, giving information about treatment options, consent, gathering, end of life conversations, and emotional support. Okay. So what are the communication principles that you need to know? Okay. So that usually involves preparation. So whenever you're trying to start a conversation, you should have a private, quiet environment. It should have minimal interruptions. It should be having appropriate seating. You cannot make, the patient's relative to stand up while you are sitting down and talking to them. And you should have a team introduction. Always make sure that you introduce yourself before you start a conversation. So these things become very important in your practical session. Okay. So in start the conversation by making sure that the family is comfortable, then introduce yourself, and after that you start your conversation. So after that, when you start a conversation, start it by knowing the assessment, how much the patient's family or the patient can understand about medicine or the particular condition. Okay. And you have to make sure that you have a clear communication objective. If you have gone there for a consent, only keep it to consent. Okay. Don't prolong a conversation if it is not necessary. Always understand the emotional state of both the patient and the family when you are talking about anything. Okay. That has to be involved in assessment. After assessing the family and the patient, you come to the delivery of the communication. The delivery of communication should be very clear. It should be compassionate. Okay. It should be very honest. Don't beat around the bush and be very clear about it. Don't give any unnecessary hope when it is not there. But if there is any hope present, please tell them about the options which are available. Okay. Always talk to the patient with some amount of evidence. Okay. So don't give them vague hopes or vague numbers so that they do not understand. There has been a lot of issue when the patient comes and tells if they've given 90% chance, 80% chance. Those are not the numbers that I mean to say. It's only whether there is benefit of doing a particular modality. If someone comes and asks you if you're doing probably in a case of GB syndrome, is plasmapheresis or plasma exchange better? You're talking about IVIG versus plasma. If these two things are there, which is better? So if you are asked about such questions, probably you need to tell them based on evidence. Okay. The next thing in communication is validation. Okay, it involves active listening, emotional support, and checking the comprehension. So whenever you give information to the family, make sure that they are understanding and they can get back to you. Always ask them to, repeat something to you or ask them, have you understood when you're talking to them? Okay. Always follow up with them, have a documentation, refer them to any services that are necessary, like, in case of Eolc practices, refer them to a palliative specialist or a PMR specialist or any other person that is necessary. Always check in periodically with the family about whatever you have spoken about. Okay. So whenever you're talking about communication, you have to do it under those things. So whenever you have a case scenario, probably you have a patient in the ICU and you need to communicate. So when you have to communicate, it depends on two important things. Okay. What is the situation? Whether it is an emergent situation or it's a planned decision. Okay. If it is an emergent situation, it is going to be very crisp. Okay. The message should not take much time. Okay. And you should always make sure the person receiving the information should be able to understand and give you an informed consent. Okay. So this is necessary because this time is of the essence here. In a planned discussion, you should always give them the time to, take in the information, process the information, and then get back to you. So this is majorly which is necessary. Once they're able to understand that, probably at that particular time, in a place where it is non-emergent, you can talk to them about prognosis, treatment options. Along with that, if it is a case of end of life care, etc., then you can give emotional support as well. Okay. After understanding all of that, you should have a thorough documentation, a follow-up plan. Okay. And then this has to be followed up with periodic checkups. Okay. So when coming to comprehensive approach of breaking bad news, usually end of life care decision is something that needs to be very accurate and appropriate. Okay. You cannot tell them something that is unnecessary at that particular time. Probably giving more information at that particular time can lead to more confusion. Okay. You should assess and elicit problems which are there at that particular time regarding the illness, and any conflict, if it is present, should be resolved. Okay. Preliminary approach, more or less, it is the family which participates in end of life decision making. Always go under the following mnemonic. Okay. That is the value mnemonic. Value the statements made by the family members. It becomes very important to, not have a patient's family come back to you later on telling that I have not understood, and you killed my family member because I had not understood that thing. So always value their statements, acknowledge the family members' emotions, listen to what they have to say, understand what the patient or the family wants to do. Okay. And then plan a decision. And always elicit questions from the family members. Ask them, have you understood? Do you want something else? I hope it is clear. Something like those. Ask them leading questions so that they are very clear before they take the final decision. Okay. So there are multiple things that have come into, vogue. I mean, these are smaller mnemonics that have been routinely asked. For non-verbal communication, it is the solar approach. Solar usually stands for squarely at eye level. So always whenever you're talking to the family members, the physician usually has to sit very comfortably, in a dignified manner. Make sure that you're having eye contact. The body posture is very important. You have to have an open body posture. Do not cross your arms. Do not sit across the table. Lean forward. Whenever you lean forward, that is a sign of indication that you are interested in their concern, or you're showing some concern to the family. Throughout the conversation, maintain your eye contact. Always show a relaxed posture. Okay. Do not be in a position wherein you sit at the edge of your seat, and as soon as you finish the conversation, you are ready to run away. That is what they mean by relaxed body posture. Okay. You have to be very calm and composed. Okay. Give them time. Probably after you end the conversation, be there for a minute or so, because they might be taking some time to digest the fact and they can get back to you with some question. Okay. These are the non-verbal communication. The acronym is SOLAR. Okay. Uh, Whenever you're talking about patient family-centric approach, that is the spikes mnemonic that has to be taken into consideration. It involves setting that I've already spoken about, calm environment, no noise, make sure that the patient family is comfortable, you're comfortable. Okay. Introduce yourself and then start it. Look for the perception, invite questions from the family, assess the knowledge of the patients. Okay. Reassess whatever you have spoken, whether they have understood. Check for emotions and, give them some emotional support. Summarize the whole thing. Usually summarizing will help you. You can either ask them to summarize. If they're unable to do so, you can summarize it for them and ask them if they have understood or followed you. Whenever you do so, start your conversation after your introduction by asking them what they are comfortable with. The language is one important thing which comes into consideration. Okay. So I've already spoken to you about all these things. That is setting, perception, invitation, okay, and knowledge, emotions and strategies. Okay. So conflict is one more important thing. This I just added as an add-on thing to the talk. It was not intended to be there, but since we have been seeing that one of the stations in the Viva session is conflicts and communication, I just thought I will just throw in some light, if at all it's asked as a theory questions. So types of conflicts can be professional conflicts, that is between you and any other team which is involved. Okay, so you can have disagreements on the treatments or the methods, etc. Okay, usually there is a hierarchy which goes on in every place. There might be communication breakdowns, which is probable because of poor handovers, etc. Okay. The next thing which is important, or the conflict we see, is between the patient and the family. Okay. Usually treatment decisions, prognosis understanding, resource allocation, especially financial issues, can be one of the things. At that particular time, end of life choices also becomes really difficult. Probably the patient's intentions might be different and the family's intentions might be different. So that actually throws in some conflict there. Okay. Ethical conflicts can, arise about treatment futility, autonomy of the patient, especially when they're incapacitated, resource limitations, cultural differences, etc. Okay. So this is in just about other things that I wanted to talk to you about. That is environmental factors, physician factors, and family factors. Okay. This is more or less the same, which I've already mentioned to you about. Okay. So how do you resolve problems regarding conflict? Have better communication. You practice something called as active listening. Have an empathic response. Okay. So the approach should be empathetic. Clear communication, neutral language, and respect to all parties involved. Emotional management becomes very important. Validate the feelings of the individual. That is very important. Probably if you recognize and validate their feelings, probably their incidents are, the chances of them accepting whatever you're saying and your communication would improve and the conflict would be resolved. Okay. Most of these things have been taken from this particular article. That is the 2014 integrated plan for dying. Okay. So you can refer to this article. I've already uploaded in the article sections. Okay. Thank you. Any questions? I think so. I've exceeded by some time. Guys, you need to read this again. Okay. That is something which is very much necessary. This is quite dry. I tried to make it as, interactive as possible, but unfortunately I was not able to do so, I guess. But if there's anything, feel free to, text or communicate in the WhatsApp groups. Thank you. Ma'am, I think so you can carry on.
Yeah, thank you, Darshan.
Thank you.
So palliation care is a very important topic, and it's an expected question for your exams this year. So please go through the newer guidelines in detail. So I'm sorry that we have not informed you that there is a change in the time of the topics. So we have just started with Eolc. Next, we'll be dealing with endocrine, 4 important topics, followed by Tapas sir will be doing in the last about the brain death and management of the organ donation. So we'll go with endocrine. So are my slides visible?
No, ma'am. Only the screen is seen. Your list of.
Okay, just one sec. Now able to see it?
Yes, ma'am. Now it is seen. Yeah.
Okay, thank you. So next 2 topics would be around about the thyroid storm and SIDH. So I think thyroid storm, I think most of you people will know. I mean, in your post graduations also, this is a common question that has been asked. So this would be just a revision for you people. So we'll be discussing about introduction, what are the precipitating factors, pathophysiology, the clinical features, how to diagnose, treatment, and complications of thyroid storm. So coming to the introduction, so thyroid storm is a rare, but it's a serious condition which carries high rate of morbidity as well as mortality. So before going to the actual definition of thyroid storm, we should know 2 important terms. One is what is hyperthyroidism and one is thyrotoxicosis. So what is hyperthyroidism? It is nothing but the result of excessive synthesis and secretion of thyroid hormone from the thyroid gland. That is known as hyperthyroidism. Now, what is thyrotoxicosis? It refers to the clinical manifestations of the symptoms due to excess T3 and T4 in the peripheral tissues, regardless of the source. Okay, so that means thyrotoxicosis. Now, what is thyroid storm? It is a life-threatening condition which is characterized by exaggerated signs and symptoms of this thyrotoxicosis with addition of multi-organ decompensation. There should be a multi-organ decompensation, then only you can tell that it is a thyroid storm. Otherwise, it would be only thyrotoxicosis. Okay, so these are the three important definitions that you should know. Now, coming to the precipitating factors. So the most common precipitating factor is any interruption in the drug therapy which is being given for the patient for hypothyroidism, or any medication non-adherence. The others could be Graves' disease, any infection, patient undergoing a thyroid or a non-thyroidical surgery, acute MI, any pregnant lady who has having a preeclampsia or a patient with hydatiform mold, trauma, burns, any exposure to exogenous iodine, like if the patient is undergoing any contrast or if the patient is having any radioiodine therapy for any CA, or medications, most common medications like amiodarone, lithium, sunitinib, interferon alpha may cause thyroid storm. And in around 24 to 43% cases, it could be idiopathic or no identifiable trigger. Now, we should also know what is the most common cause of death in thyroid storm. The most common cause is multi-organ failure, okay, followed by there could be a congestive heart failure, respiratory failure, any dysarrhythmias, DIC, GI perforation, hypoxemic brain injury, and sepsis. So these are the common causes of death in thyroid storm. So as I told, most common causes are any medication non-adherence, underlying Graves' disease, and infections. Others are drugs like amiodarone, emotional stress, non-thyroid surgery, preeclampsia, pregnancy or labor, psychosis, and trauma. Okay, there are other rare causes. Just remember the common causes. That's more than enough. Now, coming to the pathophysiology. So before going to actually what happens in thyroid storm, we should know normally how this thyroid gland is been, how are the hormones synthesized and how is the negative feedback has been maintained. So basically, the most important structure which is involved in this hormonal balances in thyroid is the hypothalamus. So first, we should see whether the metabolic rate and T3 and T4 concentration in the blood are either low or high. Okay, if the metabolic rate is high and the hormone concentration T3 and T4 in the blood is high, then what does the hypothalamus do? It stops the TRH release, okay, from the pituitary, and this leads to the stoppage of release of TSH from the anterior pituitary. Okay, so this is the negative feedback that happens. Now, when the concentrations are low in the blood, then what does the hypothalamus do? It releases the TRH. Okay, this TRH release will lead to the release of TSH from the anterior pituitary. Now, after releasing of TSH from the anterior pituitary, this THS will bind to the receptors which are present on the thyroid gland. Okay. Now, after binding of the receptors to the thyroid gland, we'll take the example of the thyroid or the thyroid follicular cell. Now, this is the plasma, this is the follicular cell. Inside the follicular cells, you have the thyroglobulin. So when this receptors, TSH receptors, TSH will bind to the receptors on the thyroid. What happens? The iodine from the plasma, it enters into the follicular cells. When it enters into the follicular cells, in the presence of the thyroid peroxidase enzyme, the iodide is converted to iodine. Okay, this iodine will go into the thyroglobulin, okay, and combines with the tyrosine, which is present in the thyroglobulin, leading to the formation of two important things. One is the monoiodotyrosine and diiodotyrosine. Okay, So one MIT and DIT combines to form T3 and 2 DIT combines to form T4. So after this, T3 and T4 get released into the plasma and then it acts on the target cells. So as I told, the second will be the effects of TSH release. So what happens to the TSH release? It leads to release of T3 and T4 by the thyroid follicular cells, which I've showed in the next slide. After this, what happens? The effects of the T3 and T4 on the peripheral organs will happen. And then if the negative and the positive feedback mechanism can happen. Okay. So this is the normal mechanism of the release of T3 and T4. What happens in the thyroid storm? One, there could be heightened tissue response to the thyroid hormones. So T3 and T4 are produced in the normal range only, but the response of the tissues to this are heightened. That is the first one. Second, there could be enhanced binding to the thyroid receptors. Third, there could be decreased affinity of this thyroid binding proteins for thyroid hormones. Usually, 70 to 80% of this T3 and T4 is binded to the thyroid binding globulin. Okay, if there is a decreased affinity, then there is increased availability of T3 and T4 for the peripheral tissues. Fourth one is abrupt increase in the free thyroid hormone availability. And the fifth one is the loss of homeostatic interaction between the thyroid hormone and the sympathoadrenal system. Okay. Now coming to the clinical features. So clinical features can be divided into various systems. So first, the most common general systemic feature is fever. Okay, so the fever may reach up to 104 to 106 degree Fahrenheit in case of thyroid storm. There could be diaphoresis and history of weight loss. Coming to the cardiovascular system, there could be tachycardia, which could be sinus tachycardia, and a lot of arrhythmias are possible in thyroid storm, the most common being atrial fibrillation. There could be a systolic heart failure with pulmonary as well as peripheral edema. There is a high heart failure, cardiac output failure, so which is usually manifested as a vasodilated state and a warm peripheral extremities. There is a wide pulse pressure with systolic hypertension. In the GI, patient may present with nausea, vomiting, diarrhea, abdominal pain, and liver is most commonly involved. So jaundice is most commonly seen in these patients. Coming to the neurological features, there could be tremors, restlessness, patient could be severely agitated, there is severe anxiety present, and in the later stages, there could be even confusion, stupor, and coma also. The others could be the patient may have a goiter as in the history. There could be a scar from a partial thyroidectomy, or there could be exophthalmos. So these are the clinical features by which the patient of a thyroid storm presents with. Now, how to diagnose this patient? Okay, so the diagnosis is very challenging because the presentations are varied and they are usually non-specific, because high-grade fever can present with any other cases. I'm going to discuss about the differential diagnosis. So basically the evaluation should include the CBC, serum electrolytes, the renal and liver function tests, creatine kinase, coagulation profile, the thyroid function tests, ECG, and the urine analysis. Coming to the thyroid function tests, they usually present with an suppressed TSH with an elevated T3, T4 levels. And because these patients usually present with an altered mental status, you have to do a non-contrast CT to rule out any other causes of the altered mental status. Blood cultures and chest radiograph has to be obtained to rule out any other causes of this thyroid storm, like if there is an infection or any other sepsis. So we need to rule out all these as the precipitating factors. So in case of any toxic ingestion, usually acetaminophen and salicylic acid levels should be obtained, because even toxins can present with an altered sensorium with a manifestation of fever. So there are some diagnostic criteria, scoring systems, which are useful in case of diagnosing the thyroid storm. So the two important criteria are the Birch-Wartowski scale and the Japan Thyroid Association criteria. Just remember the two names, and important one is the Birch-Wartowski scale. So you have to only know the headings under this and the values which are very important. Okay, need not to go into each point. So what are the components which you have to remember is, one is temperature, what are the CNS effects, GI or the hepatic dysfunction, cardiovascular dysfunction, heart failure, and is there any precipitant history? Is there a precipitating factor? Okay, just mention these things and you have to know the score and what does it tell. Okay, so less than 25, if the score is less than 25, then thyroid storm is unlikely. 25 to 45, it tells that there is an impending storm. And if the value is more than 45, the thyroid storm is confirmed. Okay, need not to remember each of the values, just the final value is important. Okay, and the second one is, if you just remember the name, it's more than more than enough. Japanese Thyroid Association diagnostic criteria. So this also has the same thing. The central nervous system, if there is a fever, tachycardia, congestive heart failure, and the GI hepatic manifestations. Okay, here there are 5. Okay, and they are basically divided into 2. Definite thyroid storm or a suspected thyroid storm. Okay, so what is definitive thyroid storm? If there is thyrotoxicosis plus at least one CNS manifestation plus the other things, fever, tachycardia, congestive heart failure, or the GI hepatic manifestation. If these are present, then it is a definite thyroid storm. And suspected is patients thyrotoxicosis plus a combination of 2 of the following: either fever, tachycardia, congestive heart failure, or a GI hepatic manifestations. No need to have a CNS manifestation in a suspected thyroid storm. That is only difference between these 2. Okay. Now coming to the differential diagnosis. So a lot of differential diagnosis for thyroid storm. The most common is sepsis, or a patient presenting with psychosis, cocaine use, pheochromocytoma, neuroleptic malignant syndrome, malignant hyperthermia, serotonin syndrome, anticholinergics or adrenergic drug intoxication, CNS infections, and hypertensive encephalopathy. I think most of the people might be knowing that neuroleptic malignant syndrome, malignant hyperthermia, serotonin syndrome, these are one of the important differentials for thyroid storm, especially in perioperative period. So this is just one table which tells some differentiating features about these. So thyroid storm, what happens to the mental status in these patients? It is potentially impaired. Whereas if you see the pupils, it would be normal. The muscle tone would be normal. Mucosa and the skin would be normal. Okay. Whereas in malignant hyperthermia and neuromalignant syndrome, what happens is the same. The mental state would be impaired. Okay. But if you see the muscle tone, okay. Just one sec. Okay. The muscle tone would be rigid. Okay. The mucosa would be wet. And if you come to the reflexes, in thyroid storm, it is normal. Whereas in malignant hyperthermia and neuroleptic malignant syndrome, it is decreased. In serotonin syndrome, the reflexes will be increased, but the muscle tone is rigid and the pupils will be dilated in serotonin syndrome. Okay, so this is how you differentiate these 4 important things. Now, how do you manage a patient of thyroid storm? So this is very, very important. So it is basically divided into supportive measures and the specific measures. Supportive measures would include IV fluids, oxygen. You have to use cooling blankets, or basically you have to manage the hypothermia either by giving a cooling blanket or give a paracetamol. And some specific measures basically include the medical management which is used to treat the hyperthyroidism. The second one is, if any precipitating factors are there, we need to address these precipitating factors, and we need to admit all the thyroid storm patients into the intensive care unit, and you should do a close cardiac monitoring and a ventilatory support if required. Now coming to the specific strategies for hyperthyroidism. So basically 5 important steps are there. First, the therapy which is used to control the increased adrenergic tone. So what drug we use is a beta blocker. Second, therapy to reduce the thyroid hormone synthesis. So we need to stop the production. So this can be done by thionamides. Third, therapy which is used to reduce the release of thyroid hormone. Already it is formed, but we need to stop the release. So how it can be done? By the use of iodine solution. The fourth one is you have to block the peripheral conversion of T3 to T4. So it can be done by iodinated radio contrast agents, steroids, PTU, and the propranolol. And the last one is you have to reduce the enterohepatic recycling of these thyroid hormones, which can be done by bile acid sequestrant. Okay, so this is how you manage these patients. So now coming to the beta blockers. So after the initial supportive measures, any case of suspected thyroid storm, you have to start a beta blocker first. Okay, this is the first step after you give the supportive measures. So most commonly used is propranolol. You give it the dose of 40 to 80 mg every 4 to 6 hours. Also, you can use an IV beta blocker agent, which is a short acting, the esmolol. You have to give it as a loading and the maintenance dose. The loading dose would be 250 to 500 microgram per kg, which is followed by 50 microgram per kg to 100 microgram per kg per minute. If the patient has a reactive airway disease, then you can use a cardioselective beta blocker like atenolol or metoprolol. And if there is any contraindication to the beta blockers, you can use calcium channel blockers like diltiazem. Okay. Now, after this, you need to start the thionamides. Okay. So, after giving a beta blocker, you need to either start the thionamides. Two most common thionamides which are used are the PTU, propylthiouracil, and the second one is the methimazole. So propylthiouracil, if you want to give, you have to give it as a loading dose first. So loading dose would be 500 to 1000 mg followed by an 250 mg every 4th hourly. Whereas methimazole, no loading dose is required. You can start it as 20 mg every 4 to 6 hours. Okay. Advantages of giving PTU is that it has a small additional effect. That is, it basically blocks the peripheral conversion of T4 to T3. So the fourth step is also managed by PTU. Okay. So what is the effects of the PTU? If the first 24 hours, the PTU has basically decreases the levels of T3 by 45%. Whereas if you are using a methimazole, so it will decrease only by 10 to 15%. So if the patient is in a severe thyroid storm, the symptoms are very bad, then start with propylthiouracil because the effect of decreasing the hormone level is better with PTU compared to the methimazole. Okay. But as the days progresses, methimazole causes more rapid normalization of the serum T3 levels and it has less hepatotoxicity compared to the PTU. So initial 4 to 5 days, you start with PTU, then you convert it into methimazole because you can have less hepatotoxicity with the methimazole and it has more, the duration of action of methimazole is longer. So it has a better effect for the next few days. So start with PTU for 3 to 4 days. If the patient is improving, then convert it into methimazole. That would be a better way of treating these patients. Now, after 1 hour of administrating the PTU or methimazole, you have to give the third drug. That is the supersaturated potassium iodide. Okay, the iodine solution you need to give. So you have to give us 5 drops by mouth every 6 hours. So why do you need to give it after 1 hour? Why can't we give it before giving the thionamides? Because if you give it thionamides first and then the supersaturated potassium iodide, this prevents the imminent increase in thyroid hormone synthesis due to increased iodine load from the supersaturated potassium iodide. Okay, so that is the reason first you have to give the propylthiouracil, which decreases the thyroid hormone synthesis because even SSIK can lead to thyroid hormone synthesis. Okay. So post that, you need to give your steroids. So the most commonly used steroid is hydrocortisone. The dose is 100 mg every 8th hourly. Also, you can use dexamethasone. Followed by the 5th one, you have to decrease the enterohepatic recycling, for which you give oral cholestyramine 4 grams 4 times daily. Okay. And if any patient is on aspirin, please stop the aspirin because it has the increased risk of producing a free thyroid hormone levels because it interferes with the thyroid binding protein. So any patient on aspirin, just withhold it for the next 4 to 5 days. So 5 important steps. First one is the beta blockers. Second one is the thienamides. Third one, you are going to give the iodine solution. Fourth one, you have to decrease the peripheral conversion. So you give a steroid. And fifth one, to prevent the enterohepatic recycling, you're going to give the oral cholestyramine. These are the 5 steps. So suppose if the patient is having a contraindication to thienamide, you can give all the other 4 drugs, okay, and then later plan for a thyroidectomy in these patients, because you can't continue thienamides in these patients because this has to be continued for some months. So if you're not able to give this, then thyroidectomy is the last resort for these patients. Okay. So once the clinical condition improves, the iodine solution should be stopped. Glucocorticoids should be tapered and stopped. Beta blockers should be adjusted. Okay. And thienamide therapy should be titrated. And if PTU is used initially, you switch it to methimazole. So patient should be recommended for definitive treatment with radioactive iodine or thyroidectomy if the patient is having any CA. Surgery may be required in patients with grave disease to treat the hyperthyroidism, and these patients must be pre-treated with a beta blockers, glucocorticosteroids and iodine formulas prior to the surgery. Actually, you should bake them euthyroid and then plan for the surgery. So this usually takes around 5 to 7 days. And if the patient is not able to recover from this thyroid storm by whatever medications you have given, then the final resort would be plasmapheresis. Okay. Now coming to the prognosis. So it is a true medical emergency and it is fatal if it is left untreated. And if you treat it properly, most of these patients will be improved within 24 hours. Now coming to the risk factors for poor prognosis in these patients. One is if the patient has an advanced stage, if there is any neurological deficits on admission, if you have not started beta blockers and antithyroid medications for these patients in the initial 2 days, or if there is a need for dialysis and or mechanical ventilation on admission, then these are the patients who have a poor prognosis. Now coming to the complications. So the most common complication would be arrhythmias in these patients. As I told, they can go for a high output cardiac failure. Patients may have seizures, delirium, coma. There could be elevated liver enzymes and jaundice. And GI complications would include abdominal cramps, vomiting, diarrhea, and in rare cases, even GI perforation. And most importantly, atrial fibrillation and thromboembolism is common in these patients. So please give DVT prophylaxis in all thyroid storm patients. Okay. So basically, you should know what are the precipitating factors, pathophysiology, if you can remember. Okay. Otherwise, at least the management, the 5 important steps, write it as steps. Okay. And remember it. So next topic would be about SIADH. Able to see my screen?
Yes, ma'am.
So SIADH and cerebral salt wasting, both are important topics in the endocrine. So today we'll be discussing only about SIADH and just difference between SIADH and the cerebral salt wasting. So coming to the outline, we'll be discussing about the introduction, etiology, pathophysiology, clinical features, how do you evaluate these patients, what is the treatment and complications. Coming to the previous year questions, recently in December 2022, they've asked 5-mark question as difference between SIADH and cerebral salt wasting. Okay. So what is SIADH? It is a condition which is defined by the unsuppressed release of ADH from the pituitary gland or a non-pituitary source, or the continued action of this ADH on the vasopressin receptors. This is known as SIADH. Okay. This was first detected in 2 patients with lung cancer by William Schwartz and Frederick Barter in 1967. This is basically characterized by impaired water excretion. Okay, so there will be water retention leading to hyponatremia with either hypervolemia or euvolemia, but basically the most commonly it presents as euvolemia. Now, coming to the classification of SIADH. So, SIADH is classified as hereditary SIADH or secondary SIADH. What is hereditary SIADH? It is also known as nephrogenic SIADH. And what is the cause of this? Because of the gain of function mutation in vasopressin 2 receptors in the kidneys, hereditary SIADH results. Okay. Now, coming to the secondary SIADH. This is a very rare component, hereditary SIADH. The most common which we see is a secondary SIADH. And now what are the causes for the secondary SIADH? There are multiple causes. So the first cause would be about the central nervous system. So any stroke, hemorrhage, infection, trauma, mental illness, and psychosis can lead to SIADH. How does it cause SIADH? Because there could be an enhanced ADH release from the pituitary gland in these cases. So this is a cause of CNS SIADH. Now coming to the malignancies. The most common malignancy is the small cell lung cancer. The others could be extrapulmonary small cell carcinoma, head and neck cancers, and olfactory neuroblastomas. So in these cases, ectopic ADH release is a cause of SIADH. Coming to the drugs. So what does all these drugs do? They enhance the release or the effect of ADH. Either they enhance the release of the ADH or they enhance the effect of ADH. The most common drugs are carbamazepine, oxcarbamazepine, chlorpropamide, cyclophosphamide, and SSRIs. Coming to certain surgeries, which are usually associated with hypersecretion of ADH, these may cause SIADH. Coming to the pulmonary diseases, infections like pneumonia, asthma, atelectasis, ARDS, and pneumothorax can also lead to SIADH. The mechanism is unknown. And any hormonal deficiencies like hypopituitarism or hypothyroidism may be accompanied by this SIADH. So in such cases, you have to correct the hormones. That is, if there is a hypothyroidism, provide TSH so that the SIADH is being corrected. And the last one is hormone therapy. So we use a lot of hormones for the treatment of different underlying conditions. So these also can lead to SIADH. The most common is, so to control the GI bleed, we use vasopressin in CLD patients. So that might cause SIADH. Desmopressin, especially to treat von Willebrand's disease, hemophilia, or platelet dysfunction, this might lead to SIADH, and oxytocin to induce labor may also lead to SIADH. Okay. So here, what is the mechanism? They increase the activity of the vasopressin 2 receptors. So this is the causes of the secondary SIADH. Now, what is the pathophysiology? So first we will know what is the normal role of this arginine vasopressin or the ADH. So basically this is formed in the hypothalamus and it is stored in the posterior pituitary via the pituitary stalk. So what is its main function? It is nothing but the osmoregulation. What is osmoregulation? Basically to maintain the plasma tonicity. So this is the main function of the vasopressin. So this plasma tonicity is basically determined by the effective osmoles which are present in the extracellular fluid. So what is that effective osmole? It is nothing but the sodium. This sodium is not freely permeable across the cell membrane. Okay. What are the other osmoles which may actually determine the osmoregulation? There are the other two, the glucose and the urea. But these are ineffective osmoles. Why? Because they are freely permeable across the cell membranes and they do not take part in maintaining the plasma tonicity. Okay. So whenever you want to calculate the serum osmolality, so 2 times the sodium concentration is the thing which we usually calculate because glucose and urea are ineffective osmoles. Now, osmoreceptors, they detect the change in the effective plasma osmolality in the hypothalamus. Okay. Now, what happens if there is a decrease in the tonicity? If the plasma tonicity is decreased, okay, so the osmoreceptors, what they do? They prevent the release of ADH from the posterior pituitary. So, what happens? There is prevention of water retention. Okay. But if there is an increase in the tonicity, these osmoreceptors, they release the ADH from the posterior pituitary. So when ADH is released, this ADH, they act on the V2 receptors, which are present on the luminal surface of the cortical as well as the medullary collecting tubular cells, okay, which are present in the kidney. So when they act on this, there is formation of something known as aquaporin 2 water channels. So when these are formed, what happens? There is water resorption, which is nothing but water is absorbed down the concentration gradient. That is known as water resorption. So what happens when there is an increase in tonicity? Decrease in tonicity. This is a normal phenomenon which usually happens. Okay. But what happens in SIDH? In SIDH, there is increased levels of ADH. As I told, it could be either from pituitary or it could be from the non-pituitary sources. Okay, so when there is an increased levels of ADH, what happens? The renal tubules are permeable to water, leading to water resorption. As I told, the same thing, but this happens in an above the normal range. So what happens if there is an increased water resorption? Three things happen. One is there is decreased urinary volume leading to increased urinary osmolality and increased urinary sodium. Okay. Second thing, when water is reabsorbed, what happens to the blood volume? There is an increase in the blood volume. So what happens to the serum osmolality? It is decreased. And that leads to dilutional hyponatremia. Okay, so the sodium is lost in the urine, and because of the increased blood volume, there is a dilution hypernatremia also. And this water resorption also leads to decreased aldosterone, leading to increased urinary sodium and dilutional hyponatremia. So this is how in SADH there is hyponatremia, that too a euvolumic hyponatremia. Okay. Now coming to the clinical features. So I think last time while discussing about the electrolyte, Dr. Darshan has told about hyponatremia and something he mentioned about SADH and um, what are the, how to correct the SADH, how fast it should be. So we'll just go through it. So the clinical features of SADH is basically two things. One is the clinical features which are related to hyponatremia, and second, okay, what happens to the water which is present in the plasma? It moves into the cells. So the rapidity with which it moves is also important. So cerebral edema is one of the other manifestation of the SADH. So the clinical features which are related to hyponatremia and the clinical features which are related to cerebral edema, both these constitute the clinical features of the SADH. Okay. Now, as we know, hyponatremia can be classified into mild, moderate, and severe. Okay, so mild. So usually they present as asymptomatic, or in some patients there could be mild headache, nausea, vomiting. There could be some confusion and anorexia. In moderate hyponatremia, the clinical features includes gait disturbances. There could be headache, vomiting, confusion to a larger extent. There could be depressed deep tendon reflexes. And when it is severe hyponatremia, there could be delirium, seizures, brainstem herniation, respiratory arrest, coma, and even death. Okay. So how do you evaluate these patients? So as I told, secondary SADH is more common. So we need to evaluate for the causes of the secondary SADH. So in the history, we need to see whether the patient had a head injury, if the patient has a chronic pain and is on pain medications, if the patient has a history of smoking, weight loss, or any pulmonary symptoms, any drug intakes, or a substance abuse, particularly heroin and ecstasy. These also leads to SADH. Second, you have to do a physical examination. Okay, basically, why physical examination? To assess the volume status of these patients, whether hypovolemic, hypovolemic or hypervolemic or euvolemic. This has to be done in the physical examination, and you have to also do a detailed neurological as well as chest examination. Now, there is one important criteria which is, which is present to diagnose the SIADH. That is nothing but those people who have invented this term SIADH, the Schwartz and the Barter clinical criteria. This has been given in 1967. So whenever a patient of SIADH you have in doubt, please see whether he fits into all these criteria so that you can easily diagnose SIADH. So what are the criteria? First, the serum sodium should be less than 135. Okay. Second, you need to send for a serum osmolality, or you can even measure it. Okay. Serum osmolality should be less than 275. Okay. Whereas I told urinary osmolality will be high, right? So it will be more than 100 milliosmoles per kg. Okay. So serum osmolality will be less, urine osmolality will be increased. Whereas what happens to the urinary sodium? As I told, there is a lot of sodium excreted in the urine. So when you measure it, it should be more than 40 milliequivalents per liter. Okay. So these are the 4 things which you need to send in a suspected patient of SIADH. Then you see to the volume status. So there should be an absence of clinical evidence of volume depletion. Okay. There should not be any evidence of hypovolemia. Next, you should rule out the other causes of hyponatremia. Like there is no adrenal insufficiency, there is no cardiac failure, because there will be fluid overload in such cases. So there will be dilutional hyponatremia. There should not be any hypothyroidism. Okay, there should be no pituitary insufficiency. So you should basically rule out other causes of hyponatremia. And if there is if the hyponatremia improves with fluid restriction, then this could be a SIADH. So all these criteria should be fulfilled. Then only you can tell this, yes, this patient has a SIADH. Okay. Renal function tests and random blood sugar tests should also be checked, because these are the potential causes of pseudohyponatremia. So you should also rule out pseudohyponatremia at first, and then all these criteria. Now, as I told, labs, what all to be sent? So serum sodium, urine sodium should be sent. Serum osmolality, urine osmolality should be sent. And to rule out other causes, you need to send RFTs. You should measure the blood sugar level, thyroid profile, serum cortisol, serum potassium bicarbonate and chloride levels, fasting lipid profile, LFTs. And any patients with long-standing smoking history, weight loss, or pulmonary symptoms, you need to do a chest X-ray and a CT to look for the most common malignancy, the small cell carcinoma. Now, how do you treat? Okay, so treatment depends on the symptoms, whether the patient has mild to moderate symptoms or whether the patient presents with the severe symptoms. So basically, the treatment involves correction and maintenance of the sodium levels and correction of the underlying abnormalities such as hypothyroidism or pulmonary or CNS infections. Basically, the underlying causes has to be corrected and the sodium levels has to be corrected and prevent cerebral edema. These are the 3 broad steps. Now, in patients with mild to moderate symptoms, the treatment is fluid restriction. Okay, the mainstay is fluid restriction. So the goal should be less than 800 to 1000 ml per day. So you first need to restrict the fluid. Despite fluid restriction, if there is persistent hyponatremia, then you can give sodium chloride in the form of oral salt tablets or IV saline. Okay. So if you're giving oral salt tablets, better give a loop diuretic, because it helps to decrease the urine concentration as well as it increases the water excretion, particularly in those patients whose urine osmolality is much higher than a serum osmolality. Okay, in such cases, you can add a loop diuretic, otherwise not required. So mild to moderate symptoms, first is restriction of the oral water intake to 800 to 1000 ml per day. If still not improving, then you can add a salt tablet or you can give a IV normal saline. Okay. But if the symptoms are very much severe, then along with water restriction, you have to start your hypertonic saline infusion. So usually you give 100 ml bolus of 3% saline, okay, over 3 to 4 hours, okay, and the sodium levels are measured within the next 2 to 3 hours, okay. If suppose still there is persistent hyponatremia, you can repeat a bolus or you can start a infusion, okay. So a rise of 3 to 4 milliequivalent within the first few hours can be justified. So usually they tell within first 6 hours, if there is an increase in 3 to 4, then okay, your treatment is working. Otherwise, you need to then again give a 100 ml hypertonic saline bolus or you start with an infusion, okay. So now comes the role of second line therapies, in which cases you can use these second line therapies. So one is if there is a persistent SAIDH despite your fluid restriction, and in case of non-severe symptoms, please keep it in mind, it is only for mild to moderate, okay. Mild to moderate symptoms, persistent SAIDH, and you have ruled out other causes of hyponatremia, and your sodium is still less than 125. Then you can use this second line therapies. So what are these? 3 important ones. One is the tolvaptan, one is the urea, one is the SGLT2 inhibitors. Okay, I think tolvaptan, most of you people use it, but before using tolvaptan, you should also see the indications, whether it is really necessary or not necessary. Okay, so now this is just a diagram which is telling about the mechanism of action of these drugs. So as we know in SIDH, what happens? Okay, there is water resorption. So the amount of water that is excreted is less, and there is what happens to the sodium levels, the amount of sodium which is excreted is also increased. So coming to the effect on the plasma sodium, there is hyponatremia. Correct? This what happens in SAIDH. We have already seen the pathophysiology behind that. Now, what happens when we give these drugs? So first one is the tolvaptan. So what does tolvaptan do? Tolvaptan is basically an antagonist at the vasopressin 2 receptor. Okay, so when you give tolvaptan, it blocks the V2 receptors, which leads to reduced water resorption. Okay, when there is a reduced water resorption, what happens? There is lot of free water that is being excreted. So water has been excreted. Okay, so what happens to the plasma sodium levels? It normally increases. Okay, so the hyponatremia is corrected because of increased free water that has come out. Okay, this is how the tolvaptan acts. Now, urea, as we know, it is an osmotic diuretic. So urea basically acts on the nephron at 2 sites. One is in the descending loop and one is at the collecting duct. So when it acts, basically it's an osmotic diuretic, right? So it acts within the tubule and also in the renal interstitium. This is a renal interstitium. So what happens? It causes water resorption. So when it causes water resorption in the renal interstitium, the sodium content in the distal tubule, in the descending loop of Henle will increase. So when this increased sodium concentration will also go to the ascending loop of Henle. So here the concentration of sodium is increased because water has been reabsorbed here. But when you come to the renal interstitium here, the concentration of the sodium is less compared to that in the ascending loop of Henle. So what happens now? Because the concentration is increased here, there occurs a passive diffusion. Okay, there occurs a passive diffusion and the sodium concentration in the renal interstitium is being increased. This is how it basically increases or treats the hyponatremia of SAIDH. Now, as I told, the second mechanism is in the collecting duct. So since it's an osmotic diuretic, what happens in the collecting duct? Lot of water is being excreted in the urine. Okay, diuresis is happening. Okay, along with that, what happens? The sodium in the renal interstitium has been reabsorbed. So the amount of sodium that is been excreted is decreased. Okay, and the urea is also excreted. So finally, what happens to the plasma sodium? Water has been excreted, whereas the sodium has been reabsorbed here. So the hyponatremia has been treated. This is how urea acts. Okay, now coming to the SGLT2 inhibitors. So what is the role of SGLT2 inhibitors in SADH? Basically, they act on this sodium glucose cotransporter. Okay, this is usually present in the proximal convoluted tubule, PCT. So what does these inhibitors do? They basically act on this and they reduce the reabsorption of glucose as well as sodium. Okay, when resorption is decreased, what happens? There will be increased excretion of the glucose as well as water. Okay, and this is how it treats the hyponatremia of SADH. Okay, so these are the mechanism of actions and these are the secondary or the second line of drugs in SADH, especially in mild to moderate cases, not in severe cases. Now coming to the rate of correction, I think it's been already discussed. So the rate of correction is an important factor in treating the hyponatremia. So it should not exceed more than 8 milliequivalents per liter per 24 hours, or it is 0.5 to 1 milliequivalent per liter per hour correction should happen. Okay, so more rapid correction can lead to osmotic demyelination. Okay, so there are some guidelines which have told the US expert opinion and the European expert opinion. So in the US expert opinion, if there is a general hyponatremia, then the target of correction should be 4 to 8 millimoles per 24 hours. This is the normal thing. And the limit is you should not correct more than 10 to 12. Okay. But if the patient has hyponatremia with the risk factors for osmotic demyelination, then the correction should be still slow. So here 4 to 8, here 4 to 6 millimoles per liter, and the limit is not more than 8 millimoles per 24 hours. This is in patients with risk factors for osmotic demyelination. Now coming to the European guidelines, their target for general hyponatremia as well as those with risk factors for ODS is the same. So their target is 5 millimoles per liter for 24 hours and the limit is 10 millimole per liter for the first 24 hours and 8 millimole per liter for the subsequent days. So these are the guidelines which tell about the correction of hyponatremia, how fast it should be.
Just Dr. Niharika, I'm just interrupting. Sorry for that. Yeah.
Sorry, sir.
So recently, in like I would say 6 days back only, there is one systematic review and meta-analysis has come from the American, the JAMA Internal Medicine about the correction rates and clinical outcomes in hospitalized adults with severe hyponatremia. And that was actually very, I would say something which would be brainstorming, because they also found that slow correction of severe hyponatremia is also associated with increased risk of mortality. So it should be optimum. It should not be too slow. It should not be too rapid. So just thought of like sharing with you. I will be like sharing in the group also. This is one original investigation just published 5 days back only.
Okay, sir. Sure. Thank you so much, sir. Yeah.
Okay, thank you.
Okay. So this is basically the management of SADH if you want to write in your exams. Okay. So patient you have diagnosed with an SADH. So you have done a fluid restriction. Okay. Of around less than 1 liter per day. So still the patient is refractory to fluid restriction. Okay. And the patient is having mild to moderate symptoms. Then you can try your second line of drug treatment. That is the tolvaptan, urea and the SGLT2 inhibitors. So tolvaptan, you can start with a dose of 7.5 mg. And when you start a tolvaptan, you allow free fluid intake. No need of fluid restriction if you give a tolvaptan. Okay, but if you're giving urea and SGLT2 inhibitors, you can do a fluid restriction in these cases. So the most common SGLT2 inhibitors which is used is the empagliflozin. 25 mg OD can be given. So after giving this, you again monitor your sodium. So sodium is improving at the target rate. If it is yes, you have to continue until the sodium normalization happens. If it is too fast, okay, so there is a risk of osmotic demyelination. In such cases, you have to cease the active treatment. If required, you can use a hypotonic fluid plus or minus desmopressin. If it is too slow, then you need to increase the correction, especially the 3% NaCl or the sodium tablets which you are giving. Okay, and then you have to reassess the if there is any underlying basically any other cause that has been attributing to this refractory therapy, you need to see for that. So now what are the complications of this SIDH? So there could be a severe headache, There could be some memory problems, depression, tremors. These are in the long standing. Okay, if there is a chronic SADH, then all this occurs. So patient may have headaches, memory problems, depression, tremors, or there could be muscle cramps. Then severe potential complications includes respiratory failure, seizures, hallucinations, coma, and even death. All these are because of hyponatremia. Now, this is one of the slide which is showing basically the difference between the SAIDH and the cerebral salt wasting. So coming to the volume status. So in SADH, it is usually normal to high, whereas in cerebral salt wasting, it is low. Coming to the urinary sodium levels, it is more in SADH, more than 40, whereas it is same as in case of cerebral salt wasting. Coming to the serum uric acid levels, it is low in both the cases. Coming to the initial fractional excretion of urate, if you measure, it is high in both the cases. But fractional excretion of urate after correction, okay, either it is fluid restriction or after giving a fluid bolus, if it is normal, then it is SADH. If it is still remains high, then it is the cerebral salt wasting. So this is one of the important difference between these two. So important difference is about after correction, what is the fractional excretion of urate, and about the volume status. Next, coming to the serum osmolality, it is low in both the cases, whereas the bun by creatinine level, okay, it is low to normal in cases of SIDH because it is basically a euvolemic state, whereas because of dehydration, this has been increased. The bun by creatinine value is increased in cerebral salt wasting. Coming to the potassium levels, it is normal in SADH, whereas it can be normal to high in case of cerebral salt wasting. Coming to the brain natriuretic peptide levels, these are normal in SADH, whereas it is high in cerebral salt wasting. And the basic treatment is water restriction in SADH, and you have to give a lot of fluids in cerebral salt wasting, plus or minus a mineralocorticosteroid. So this is the last slide, which basically just summarizes the SADH. So how does it present with? What is the most common cause of SADH? What is the acute risk and what are the chronic risks, and how do you correct it? Everything has been discussed. This is one of the just concluding side of SADH. Okay, thank you. So this completes the two important topics of endocrine. So next, Tapas sir, you would be taking, sir?
Yeah, I can take.
Okay, okay.
Thank you very much. Yeah. So can you tell me, like, the attendees, how many of you are actually appearing this year, the theory exam in January month? Can anybody, post in the chat box? Who else are not appearing? That would be making our job easier. Yeah. Because this is something quite alarming, that why people are actually not joining live classes. If they are depending upon the, it will not be as effective as like what we are doing now. Okay. Am I audible?
Yes, sir, you're audible. Yes, sir.
Okay. So yeah, something like no wake up alert. I every day, every class, I just post like this. Though it is not that effective, I know, but I will continue to do it. And I will be trying to. Yeah, so the people who are not appearing this year theory exam, but they are joining, so that is no kudos to you all. So thank you very much. But those people who are appearing the exam, but they are not joining, definitely it's a concern, not for us, but for you all. Okay. So yeah, so without wasting further time, so I will be discussing a topic which I think is one of the most important question that would be appearing, and that's why I have also posted in the our group also that you will be definitely getting 50 marks in your upcoming theory as well as practical exam, whether this year or the next year or the next session, whatever. Okay, so without wasting further time, I think all is well with you all, and all will be well. So let's start the comprehensive brain death determination. This is question number 1. And I bet this will be definitely asked in your theory as well as practical. In some or other way, it's not that straightforward. It would be brain death declaration. Maybe it would be the post cardiac arrest, how the patient will be posted for organ donation, how you are going for brain death declaration, then the donation after circulatory death, something like that. Maybe something related to organ donor management. So there are like a couple of questions in the theory, and also there would be many questions in your clinical case discussion and also in the grand viva. So be ready for the questions, and they will be confusing you. I will be making it very clear. They will not be asking straightforward questions. Rather, they would create a scenario and they would be asking and they would be checking your attentiveness during your training period, how you have witnessed the typical cardiac arrest cases and how you have actually dealt with the difficult communication as well as organ donation part as well as the brain death declaration part. Okay, so if you are not till now practice one the typical traumatic brain injury or brain death case, I would strongly suggest you to involve your senior and start, or maybe I can say formulate your own plan how you would be taking the history and then presenting at the bedside related to brain death. So this is one of the single most important questions. So that's why my slide is starting with the this type of notion for all of you. So clinical vignette, let's start with the clinical vignette because the clinical case as well as the this long case as well as short case, they can ask with a short case history. So a 41-year-old male, day 3 in your ICU, attempted self-hanging. Patient was asystole at the scene, and they the lay persons as well as the hospital healthcare workers resuscitated with ROAC achieved after 3 doses of adrenaline when the patient was presented to the emergency department. On your day of assessment, patient is having GCS of 3 with absent brainstem reflex responses. Now you are the attending, you are the junior consultant, you are the consultant, you are the ICU in charge, and you are directed to assess him for brain death. So this is the clinical scenario on which you have to answer the questions or you have to expand your answers. Now, the objective of our today's presentation is to define and understand brain death, its legal, clinical, and ethical implications. We'll be reviewing a little bit about historical evolution and the global perspectives, the outline of the clinical, the ancillary, and the special considerations for brain death determination. And we'll be also addressing the challenges, controversies, and the future directions. Now, coming to introduction to the brain death, this is in simple. The definition is irreversible cessation of all brain functions, including the brainstem. This is as simple as that. It is the irreversible cessation of all brain functions, including the brainstem. The core principles behind the brain death declaration or the discussion about brain death in any hospital, in any training, in any examination, why we are actually putting so much of effort or focus on brain death, because this is recognized as legal death in most jurisdictions, and this is essential. Single most important point for brain death is for organ donation and resource optimization. So if we are creating this hustle bustle in like no our clinical practice that yes, this patient is brain dead, this patient is like almost like not having any reversible signs symptoms of brain recovery, then it is all aiming towards organ donation. Otherwise we can just wait and the patient can die naturally. Now, there is a key distinction here you need to understand. Brain death is not equal to vegetative state. Clear. Vegetative state is not irreversible. There is maybe a small percentage of potential recovery still present. So brain death is not equal to vegetative state. Now, these are the three things which would be defining a brain dead patient. Patient will be in or patient is in coma. In simple terms, completely unresponsive. There is no brainstem reflexes present and patient is having apnea test positive. CAP, or you can make your own terminology. I normally like if you are so much confused in your exam, just remember the ACLS BLS protocol, compression, breathing, and the airway. So CBA. Okay. Now, why is brain death important? I have already told. The clinical relevance is there, legal and social implication is there. Now, clinical relevance is, if you are continuing our treatment, our utilizing our resource for a brain dead patient, you are actually continuing for the futile treatment, or you are advocating futile treatment, and focus is on more and more resource use, which is not at all apt in our the clinical practice in the resource limited settings, or in also in developed countries also, because you can actually utilize the manpower as well as the resource for patient who is having some or other positive outcome is there. There is relevance of the ethical implications in life support withdrawal. So if your patient is not showing any sign symptoms of recovery, definitely we need to think, we need to advocate, you need to promote that yes, there should not be the patient would be on this advanced support therapy. Rather, we should promote or we should discuss or explore the life support withdrawal. This is the ethical implication. So there here comes the counseling and communication, breaking bad news, all these things. So the questions are coming from different angles. Now, coming to the legal and social implications. Legal, it establishes the exact time of death. So when you are actually declaring brain death, this is the time at which this patient is finally, you will say, clinically, legally, patient is dead. And the most important thing, which already I have discussed, is that it facilitates the organ donation process. Once you clear that this patient is brain dead, definitely there would open up all the options and possibility of organ donation. Now, coming to the historical evolution, though it is not very important for your exam perspective, but yes, you should remember or you should know some landmark the timelines. 1959, first concept of brain death, and the Le Coma de Pass. 1968, Harvard brain death criteria introduced for the first time. 1980, Uniform Determination of Death Act, UDDA in the US. 2010, updates from the American Academy of Neurology, AAN. And global perspectives, there are lot of protocols across the countries, but yes, there are certain changes in the proper applicability, as well as the the eligibility of the brain death, as well as the criteria. Now, coming to the Indian perspective, maybe the examiner would be little bit inclined to ask you, 1994, the brainstem death legalized in India. So it is hardly, I would say, 30 years back only, brainstem death legalized in India. There is a act, HOTA, Transplantation of Human Organs Act, that was also passed in 1994. There occur subsequent amendments in 2011 and 2014, and the legislative foundation for brain death declaration and organ donation, they have actually added the brain death declaration and organ donation with these amendments. And we normally follow the brainstem death declaration in India, not based on the US guidelines. Rather, it is more towards the UK guideline. So remember, UK guideline. I would be pointing out why actually there is difference between US and UK, and what is the basic difference between the US and UK. Can anybody tell me what is the basic difference between US and UK guideline? Anyone? Which is relevant or pertinent to the brain death declaration? Anyone? The timing when you are actually declare that this patient is dead, brain death. So that is the difference between US. It is the only one examination, and you are like declaring that yes, this patient is brain dead. But in UK and in India, we normally go for two examinations within a span of 4 to 6 hours. Minimum 6 hours have to be there. Then the second examination is the brain dead time. Now, there are certain steps for the determination. Remember, there are only three things are there. Assessment of the prerequisites, confirm the irreversibility, and exclude the reversible causes. I'm making it very simple. My slides will be only having 2-3 lines only. But remember all these things, then you can expand your answer. Now, the second one is neurologic examination. In the neurologic examination, you will be going for brainstem reflexes and motor responses. And the third one is the apnea testing, where you are actually checking the absence of respiratory drive. Apnea is respiratory. So when there is absence of respiratory drive, you are going for the apnea testing. So three things. First, you will be checking that there is the irreversibility is there, and you are excluding all the reversible causes. There are no confounders. The second one is the proper examination, more towards the neurology, brainstem reflexes and motor responses. Third one is the respiratory. So that is apnea testing. Now, there are certain preconditions for the brain death determination. First and foremost, you should be having, or I will be saying, you must be having one established cause. Without a cause, you will not be in a good position to declare brain death. What is the meaning of that? There has to be a catastrophic, irreversible brain injury in the form of traumatic brain injury, fall from height, road traffic accident, something like that, or a intracranial bleed or spontaneous bleed, hypertensive bleed, something like that. And you are actually documenting it and confirming it, the injury, with the radiological or clinical way. I think it's very clear to all of you that you should be having an established cause. Now, the second one is exclude the confounders. Whether this patient is drug intoxicated, prolonged hypothermia, severe hypothermia, or metabolic derangements. I would be explaining these things also in detail. Now, the third one would be, I would be expecting that my patient at the time of examination is it at least having a stable environment. What is the meaning of that? Normothermia more than equal to 36 degrees centigrade, normal tension, and eucapnia. So one from the gas exchange, one related to blood pressure, and one related to temperature. So established cause has to be there. You have to exclude the confounders, and there has to be a stable environment. Now, there are certain common causes of brain death. I told you that you should be having some or other history, and there has to be an antecedent history of brain injury, traumatic brain injury, something like that. So there has to be certain causes of brain death. If it is present, then that is actually supporting the diagnosis of brain death. One is traumatic brain injury, one is intracranial hemorrhage, one is anoxic brain injury, usually due to CPR, one is fulminant meningitis or encephalitis, fulminant hepatic failure causing cerebral edema, ischemic stroke with cerebral edema, and herniation. So if you are getting this type of in the history or in the presentation, your the flow of events or your clinical appreciation becomes easier for declaring the brain death. Now, the first point is clear. Now, there are certain reversible causes of severe depression of consciousness. I am just highlighting, though you should remember, you are knowing most of the things. Renal or hepatic encephalopathy, severe hypothermia, severe hypothyroidism or severe hyperthyroidism, severe electrolyte imbalance, mostly hyponatremia, residual effects of the CNS depressants, residual effects of neuromuscular blockade, residual effects of recreational drugs, hypoglycemia or hyperglycemia, hyperosmolar state, hypercarbia, or hypocarbia, hypotension, meningitis, encephalitis, septic encephalopathy, metabolic or toxic encephalopathy, anoxic or ischemic encephalopathy, non-convulsive status epilepticus. That would be also one of the contributing factor for patient not able to wake up for a long time. Now, complex partial seizure, hypoxemia, overdose of anticholinergic or antipsychotic agents, hypoactive delirium. That can also be contributing to your prolonged unconsciousness, adrenal insufficiency, severe pituitary insufficiency, hypotensive encephalopathy, brain trauma, brain edema, brain abscess, hydrocephalus, carbon monoxide or heavy metal exposure, pesticides, OP poisoning, chemical nerve agent exposure, psychogenic coma or catatonia, and direct compression of the brainstem, and some or other like the lesion that is affecting your ascending reticular activating system. So these are some of the reversible causes. It is not irreversible causes. I am just trying to highlight here. In brain death, it would be having irreversible causes. So if you will know that there are certain components in your clinical diagnosis or in the presentation, definitely you are not in a good position to select your patient for brain death. So that is the whole point of putting this extensive list of causes. Now, here you are getting something which would be like the confounding factors that would be implicating some or other problem in the brain death determination. What are they? High cervical spinal cord injury. Here, what will happen? There would be some or other disturbances in the cough or gag reflex, motor response to the noxious stimulus, and there would be also like if you are having high cervical spinal cord injury, that would be result in no response to the brainstem testing with preserved brain or brainstem function. Are you getting the point? So if you are getting high cervical spinal cord injury, then patient is not brain dead, but you are not getting the responses just like what you are actually doing it in a normal patient. Now, the second one is complex spinal reflex movements. Now, here what will happen, I will be discussing this, all this Lazarus sign, then this transcranial Dopplers, then there would be like localizing to the airway. So there would be like all this confounding your like clinical examination, muscle fasciculations, ventilator auto triggering. So that would be intrinsic, extrinsic causes of your ventilator auto triggering may falsely suggest that residual brainstem function is there. But if your patient is brain dead and the patient is put in like ventilator, so you would be getting some or other like the spontaneous respiration spikes. But that is actually not the patient response or patient respiratory drive. Rather, it is ventilator auto triggering. Same thing is cardiac auto triggering. Then something related to like therapeutic hypothermia. Now, why therapeutic hypothermia? Because if the patient is in like you are putting the patient on like therapeutic hypothermia after the cardiac arrest, and then you are checking the patient for brain death, sometimes you will be confused because this therapeutic hypothermia, all the responses will be altered, like EG, evoked potential, pupillary light response, brainstem reflexes, all these things should be depressed. So lack of motor or papillary light response 72 hours after cardiac arrest, not universally reliable outcome predictors. So that is the whole point of discussing. Now, after cardiac arrest also, you have to check whether this patient's neurologic status has to be observed or monitored or examined at a particular time. Rather, you should be doing it after 72 hours. Otherwise, you would be confused whether the delayed neurologic response is due to brain dead or it is due to the post cardiac arrest status. Now, there are certain mimics of brain death. So the examiner would be sometimes asking that the similar situation would be also there where you will be confused whether it is brain death or it is something else. So brain death mimics are neuromuscular paralysis in the form of fulminant GBS, botulism, hypothermia. There are certain drug intoxications. Most common is the TCA, lidocaine, baclofen, barbiturates, paralytics, anticholinergic, bupropion, high cervical spine injury, locked in syndrome. Clear? Now, once we are now excluding the confounding factors and also the reversible and irreversible causes, we have to go for the detailed neurologic examination. Now, in the detailed neurologic examination, I have already discussed, you need to check for the key reflexes. And the key reflexes are pupillary light reflex, corneal reflex, oculocephalic reflex, oculovestibular reflex, gag, and cough reflex. Why I am highlighting only these reflexes? Because it is the reflexes that you can do at the bedside. And if the examiner also wants you to elicit, you can show them, yes, these are the reflexes which can be done in maybe 2 minutes of your time. Now, coming to the motor testing, differentiate the spinal reflexes from the brain mediated movements. Here, what you are going to do, you are actually differentiating whether the reflexes are originating from the brain or from the spine. So this is the motor testing. Now, coming to the brainstem reflexes. In the brainstem reflexes, it is pupillary light reflex. Pupils should be dilated, fixed, and do not react to light. Doll's head-eye movements or oculocephalic reflex, where it is the absence of conjugate deviation of eyes when head is fully rotated to the one side, but your like the eye movement is not there. Performed only when there is no fracture or instability of the cervical spine. So the examiner in your the exam paper or in the practical, they will be trying to know, they would be clearing that yes, the patient has not been cleared the cervical spine injury, and they would be creating a situation where you are there to go for the brainstem death declaration. So if you are going for this Doll's head eye movement or oculocephalic reflex without mentioning that I will be checking for the cervical spine instability or fracture, then they would be definitely upset that you are actually doing more harm to the patient rather than any good. Corneal reflex is absent, clear. Now you would be putting the pain pressure, no motor response to the stimulation within any cranial nerve distribution, like no response to the supraorbital pressure, painful stimuli here. No gag, which is pharyngeal reflex, stimulating the pharynx. No cough, where you are putting a suction catheter in the trachea. Vestibulo-ocular reflex, oculovestibular reflex, or calorie testing is absent. No eye movement after installation of 50 ml of ice cold water into each external acoustic meatus for 1 minute. 50 ml for 1 minute. You are not getting any response. Now, finally, in the brainstem reflex also, you are actually going for in the last apnea test, which I would be discussing later on. Now, this is something which you would be remembering. Eyes are central in the resting position, normal position when you are actually eyes to the left, head to the right. It is a normal response. Now, abnormal response is eyes are central when head is actually moving towards right. Clear? It is not that eyes would be also rotating to your right. Rather, it would be saying others the normal level in the center, but you are actually moving your head to the right. So this is the abnormal response, Doll's eye. Now, cold caloric response, normal tonic response, you are actually putting the light, and you can see here after visually checking that the tympanic membrane is intact. That you have to remember. If there is injury to your this temporal region and your tympanic membrane is completely damaged, you will not go for this caloric response test. Clear? So after visually checking that the tympanic membrane is intact, ice cold water is used to irrigate the ear canal and should produce a slow conjugate deviation towards the irrigated eye. So if you are putting the water here, eye should be moving towards the same side where you are actually putting the irrigated saline. Normal tonic response. Asymmetrical response, which is not going in this direction. Negative response, where it is in the center. Now, an absent or asymmetric response indicates that brainstem dysfunction is there. Either it is absent or asymmetric response. It should go to the side of your irrigation. That is the normal response. If it is staying in the middle, or there is something happening, one eye is moving towards that side, the other side is remaining in the straight, so that is asymmetric response. Intact eye deviation with nystagmus suggests that the patient may not be in coma. That means it is remaining in the the center, and there is a nystagmus happening. So that would be also saying that the patient may not be in coma. Now, this Doll's eye reflex, I have already explained. This test should not be performed if a cervical spine injury is suspected. Observe the motion of the eyes while passively moving the head. In a comatose patient, conjugate movement of the eyes in the direction opposite to the head movement is expected. An absent or asymmetric response in an unconscious patient implies brainstem dysfunction. Clear? So you should not be confused. Now, this is all the reflexes with their cranial nerve distribution, the examination technique, and the examinations, the findings are consistent with brain death or not. One is oculocephalic. What are the nerves involved? Some examiners would be very keen on asking what are the cranial nerves you are actually checking. The afferent pathway. Oculovestibular, again, the afferent. Here 3, 4, 6, and 8 involved with the pons and midbrain. Corneal, 3, 5, 7, and pons. Cuff or gag reflex, 9 and 10 with medulla. And pupillary light reflex, 2 and 3 with midbrain. Clear? So I think you all know it, but I'm trying to give a comprehensive overview that you will not get anywhere in any book. Now there are certain limitations. Spontaneous body movements observed at any point during the brain death examination may represent spinal reflexes, and that is occurring almost up to the tune of 20%. So in 20% time, you will get some or other spontaneous body movement during your examination for the brain death. And this would be difficult to discern from the respiratory effort. There would be sometimes also on the ventilator, I have already told the ventilator will auto trigger. So you will not be finding that this patient is not having any respiratory effort also. Now, findings may include pronation, extension reflex. There are certain reflexes. The examiner would be asking sometimes that what are the atypical reflexes that you will be getting while you are examining for the brain death. Pronation, extension reflex, abdominal reflex, flexion reflex, Lazarus sign, periodic leg movements. That should not be misinterpreted as brainstem functions. Evidence of brain death comes from consistent clinical examination and imaging. Now, these are the spinal reflexes that one person can get while they are examining for brain death or the donation after donation for the death after the with the neurologic criteria. Death with neurologic criteria. So I'm again highlighting all these things. You don't need to remember, but at least if the examiner is so keen on asking you 4 or 5 things, so that you can get this hugging sign. It is very interesting. Actually, I have got in my the training period in Toronto, one patient was in ICU, and when we tried to exam for the brain death declaration with my attendee, so the patient started moving and coming towards the examiner like this, hugging. So that was something very I would be not expecting that when you are actually declaring brain death and you are trying to put some pressure to check or the motor reflexes you are checking, and the patient starts moving like he or she is trying to actually sue you or kill you, something like that. So that is something very unfortunate happened, and we didn't know at that time that this is also one of the spinal reflex. But in front of the family, sometimes during the DCD, the donation after circulatory death. So when the family is there and you are trying to withdraw the support and the patient starts moving at that time, so you feel horrified or something. Okay. Now coming to the apnea testing. Here also preparation is important. You have to pre-oxygenate with 100% FiO2 and the PaO2 should be minimum 200 or more than that. Ensure that this patient is having stable hemodynamics. You have to execute then, and how you are executing? Disconnect the ventilator, monitor for the spontaneous breaths. Positive if your PaCO2 is more than equal to 60 millimeter mercury, or patient if you are having a chronic CO2 like retainer, so rise has to be more than equal to 20 millimeter mercury from the baseline, and there has to be an arterial line. There has to be some preparation that you need to do, and the challenges are during this test patient may go for the neurogenic pulmonary edema, or patient can result in hemodynamic unstable. So something like that you need to be prepared. Now the preparations has to be, I have already told, you have to stabilize the systolic blood pressure more than equal to 100 millimeter mercury. Yes, you can use inotropic agents and vasoactive agents, and that is necessary because of loss of vasomotor tone. You have to stabilize the body temperature more than equal to 36 degree, 36.5 degree, whatever may be. Apnea testing can be done at lower temperature, but at additional time required for increase in carbon dioxide, risking cardiovascular instability. It can be done at a lower temperature, but yes, the carbon dioxide will slowly build up. So you have to give some time, maybe 10 minutes, 12 minutes during the apnea testing. Normalize the PaCO2 range of 35 to 45 millimeter mercury. Maintain adequate circulating blood volume beforehand. Give some crystal oil, colloid, blood products. Try to replace the volume loss and correct the absolute or relative hypovolemia. Administer 100% oxygen for more than equal to 10 minutes to get the PaO2 more than equal to 200 millimeter mercury. Now, here comes the role of ancillary testing. Because you have done the neurology examination, the brainstem reflex, still apnea test is not 100% always you can do. Indicated the ancillary testing when a neurologic examination or apnea test could not be performed or its validity comes to the question, because the patient suddenly during the apnea testing developed neurogenic pulmonary edema. Patient is having craniofacial trauma. So you are not able to do the brainstem reflexes, and in chronic CO2 retainers, you are still confused that this rise in the CO2 is actually predicting the apnea test positive or not. So in some protocols, ancillary tests are used to shorten the duration of observation period. For example, if the patient is completely having the the hypoxic brain damage or anoxic brain damage, and you are 100% sure that this patient is not having any brain activity, so you also go for ancillary testing immediately to know that yes, this patient is no more, and go for the brain death declaration and organ donation. Now, what are the types of ancillary test that can be divided on the basis of whether there is absence of cerebral electrical activity, for example, EEG, evoked potential, or cerebral blood flow on the imaging like DSA, TCD, CT angiography, a magnetic resonance angiography, nuclear scintigraphy. So there are two types of the ancillary tests based on the mechanism, absence of cerebral electrical activity or blood flow. Now, one is DSA, which is gold standard for detecting cessation of your cerebral blood flow. But yes, you will not get DSA in all the centers. Now, the SPECT, which identifies metabolic activity or inactivity in your brain, advantage is it is non-invasive, widely accessible, but yes, your center has to have. Now, TCD, which is a portable thing, bedside option, but yes, depended on good bone window. If you're not getting that bone window, patient is having traumatic brain injury with surgery has happened. This the skull one person is right now, the bone window is right now not there, and it is in the abdomen. So you will not get a proper window. So you will not get the flow. Now, EEG, cortical activity detection, as it is cortical activity, you will not get the brainstem utility properly. So this is again the limitations and the advantages. You should remember. Now coming to one by one, EEG. EEG not generally ordered or recommended as a confirmatory test. Remember, don't advise that EEG to just now declare for the brain death. But if you are getting a persistently flatline EEG for 24 to 48 hours after anoxia, that gives you a terrible prognosis in your patient. Now, in ICU, there are certain limitations of this EEG. In the ICU setting, interpretation is affected by artifacts, leading to potential false negatives. A flatline EEG can be found in the absence of brain death, like in the drug intoxication also. So flatline EEG not confirmatory. Muscular artifacts may cause the EEG to appear activity, to active when there is no brain activity. So if there would be certain changes, certain artifacts, EEG, if you are getting electrocerebral inactivity for at least 30 minutes with intense somatosensory or audiovisual stimuli, definitely this is very suggestive of your patient not having any brain activity. And one major limitation is it detects only cortical activity reliably, cannot assess posterior fossa or brainstem. Clear? Now, this is the difference between something which is in a normal patient or a patient who is not brain dead and a patient with brain dead. You can see small spikes here, but these are some artifacts. but this should something or reliable. Patient is not having any brain activity in the EEG. Clear? Now, cerebral scintigraphy, most useful confirmatory test, technetium 99 you are using, isotope, no radionuclide localization in the MCA territory or SCA territory or basilar artery territory, and there is a terminology called hollow skull or empty bulb phenomenon. So if you are using this cerebral scintigraphy, you are getting nothing is inside the brain, whether it is in the anterior, the slice or the lateral slice. So this is named as hollow skull or empty bulb phenomenon. Now coming to the digital subtraction angiography, this is the gold standard. No intracerebral filling of carotid or vertebral artery at the level of entry into the skull. You can see here at the level of entry, here the blood flow is there, but after that there is no blood flow in the skull. So there is patent external carotid circulation. This is expensive, invasive, may not be widely available. But remember, this is a gold standard. Transcranial Doppler, useful only if you are getting a reliable signal, and the abnormalities will be including either reverberating flow or small systolic peak, cerebral circulatory arrest. So there would be reverberating or reversal of the flow. Portable, the advantages are portable, non-invasive, inexpensive, readily repeatable, bedside assessment tool, and it would be reducing the diagnostic delay if you are sending the patient for CT or MRI or something like that. Now, CT or MRI angiography, lack of intracranial arterial contrast opacification. So you are putting the contrast, but it is not going inside because there is no blood flow only. But yes, the limitation, you need to transfer the patient to the radiology suite. And this is one article you can go through, point of care transcranial Doppler by intensivist, and there they have made it cerebral circulatory arrest criteria, oscillating waveform, small systolic spike, and disappearance of all intracranial flow. So something like that. You just remember 2-3 points. Now, there are certain differences between adult and pediatric. In the examination, maybe some one type of examiner, they would be also going towards a little bit pediatric region. So in the pediatric, there are certain unique challenge. What is that unique challenge? Open fontanelles that alter the intracranial dynamics, because the pediatrics, the fontanelles are actually not fused. So there is some space to accommodate the intracranial pressure or cerebral edema. So maybe immature reflexes complicate the assessment. So you have to be using the ancillary test more rather than only these brainstem reflexes or the examination, neurologic examination for the motor response. And go for the two separate exams, often 12 to 24 hours apart. Don't make it within 6 hours. Better to go for a little bit wider gap, and prefer the reliance on the ancillary testing. Now, if the patient is on ECMO, again, this is again a question the examiner would be very keen on asking you, because in ECMO, you will not getting the complete blood flow loss. So the challenge is that ECMO supports the cardiopulmonary function. So you are masking the clinical signs. That would be you require carbon dioxide buildup adjustments during apnea testing. And the approach should be, you should be getting the sample from the arterial as well as the circuit gas sampling. Are you getting the point? So normally what we are doing, we are actually getting the blood sample from the artery, maybe radial or the femoral. But here in the patient who is on ECMO, you should be getting the sample from the circuit gas sample also, from the circuit also. And you have to ensure that sweep gas flow to actually allowing the carbon dioxide to rise. So you have to check the sweep gas flow in the ECMO circuit. Now, just few lines. Still, you are going for apnea testing. Pre-oxygenation has to be with the ECMO gas flow to 100% FiO2. Minimize the sweep gas flow rate, as I have told, carbon dioxide clearance rate to 0 to 1 liter per minute to prevent the exchange of carbon dioxide for oxygen in the membrane oxygenator. You have to minimize the sweep gas flow rate, and the target pH and carbon dioxide level should be same for both the sides. Recommendation is same only, pH 7 less than 7.3, PaCO2 more than equal to 60, and don't depend upon the TCD. Why? Because TCD is based on the pulsatile flow. But here in the ECMO, you are not getting pulsatile flow because it is extracorporeal support. So use of ancillary testing, caution should be taken with the use of TCD as it relies on the measurement of pulsatile flow. So these are some differences the examiner may keen on asking whether you are knowing about the ECMO practice or not. Now, I have already told hypothermia. Again, the other confounding hypothermia already the blunts the brainstem reflex as well as prolongs the drug clearance. So better you should go post rewarming. You should wait for 24 hours, then go for checking because that time the half life would be more and that would be excreting the drug and the effect on the brain would be weaned off. So ensure metabolic stabilization before the clinical evaluation. Now, when to determine the brain death? What would be the time? Avoid unnecessary delays once prerequisites are met. Observation period depend upon your local protocols. Again, the pediatric versus adults. Conduct the testing in the ICU. Emergency, don't go for the brain death declaration. Emergency settings in the ER. Rather, in a stable environment, go for this brain death declaration. Now, there are certain common pitfalls. You are not going for the confounders or you are actually confused with the spinal reflexes or insufficient documentation and deviation from the checklist. Don't depend upon your clinical acumen. You should be having a clinical checklist in your ICU or you create your own while you are actually putting one tick and you are checking something. Then communication with family approach has to be very clear, empathetic language to explain the brain death, discuss the prognosis and the organ donation options early. But yes, you are not involved in the organ donation discussion. Rather, the social worker, there is a different team in your hospital, they may be discussing. If you are involved in the treatment part, you are not getting the opportunity to, or you are not allowed to discuss the organ donation part. The key message, the patient has died though supported by machines, and sensitively address the cultural and the emotional concerns. Now, there are certain controversies. I'm not going to detail. You will be getting some or other pitfalls or confusions. Who will certified brainstem death? Sometimes the examiner would be asking. So there are actually, as per the board of medical experts, these following persons they have to be there in a panel of doctors: doctor in charge of the hospital, medical superintendent, doctor nominated from a panel of doctors appointed by the appropriate authority, neurologist, neurosurgeon, intensivist nominated from a panel appointed by the appropriate authority, and doctor treating the patient. So the primary consultant, whoever may be, there has to be one person from the neurology, neurosurgery, or intensivist. Then one doctor nominated from your hospital, panel or appropriate authority, and medical superintendent. The panel of 4 doctors carries out the test together to certify brain death. Now, there are certain contraindications of brain death also. Age more than 86 years, it is a rough thing, but yes, advanced age, it is again, you have to be very clear. Extreme immaturity also, less than 500 gram or gestational age of less than 32 weeks. Active malignancy with evidence of spread outside of the affected organ within 3 years. Melanoma except completely excised stage 1 cancers. Choriocarcinoma. Active hematologic malignancy like myeloma, lymphoma or leukemia. There is one acronym that you can or one mnemonic you can create for you to easily remember: CHUMP. This is C for CJD, Creutzfeldt-Jacobs disease, H for HIV, U for uncontrolled infection, any infection in the donor because you are going for the organ donation. So donor sepsis, M for metastatic or non-curable malignant disease, and P for past history of malignancy that poses risk of transmission no matter how long you are actually having your disease-free period. There are 2 examples, melanoma and choriocarcinoma. If the patient is having, you are not for the organ donation. Now, there are certain organ specific contraindications like liver, active or acute hepatitis, cirrhosis, portal vein thrombosis, kidney, CKD, stage 3B and below, pancreas, insulin dependent diabetes, and any history of pancreatic malignancy. Now, how quickly should the donated organs by a deceased or donor to be transplanted? Now, the bottom line is healthy organs should be transplanted as soon as possible. But there is again some timelines. Heart 4 to 6 hours, lung 4 to 8 hours, intestine little bit more 6 to 10 hours, liver again further 12 to 15 hours, pancreas 12 to 24 hours, and kidney can wait till 2 days. Remember, so heart is the most sensitive organ out of all the the solid organs. Now, determination of brain death, I was discussing that in the initial stage. What is the difference between US and UK? In US, only one apnea test. UK, two apnea test. Second test can be done anytime after normalization of the blood gas after the first test. And in India, same, two tests. So that's why we follow UK guideline. Second test after an interval of 6 hours. And time of death, time when, as per the American Association of Neurology, time when PaCO2 reaches its target value during the second apnea test, after confirmation of the post ancillary testing, and when first test confirms the absence of brainstem reflex. That is United Kingdom. But always, in India, we normally go for the second test, but you have to have the first test positive time mentioned. These are some of the checklist. In the examination, they may ask you, can you show some type of format in your ICU that you use, so you can always remember, though you may be using, may not be using. There has to be one, there are 25. Remember 25, the checklist are there. Prerequisites all must be checked. Just see it, then you don't need to mug up for your examination writing in the theory. First one would be coma. We all know patient has to be in coma, irreversible, and you need to know the cause. I have explained everything. Then the second one, you need to have one neuroimaging that explains the coma. Third point, confounding factor, sedative drug effect absent. Then if you are being any doubt, go for a one tox screen. 4, no residual effect of paralytic drug. If you are using it or patient is has on muscle paralysis, use the PNS, peripheral nerve stimulator. Fifth, absence of any acid-base electrolyte or endocrine abnormality. Patient has to be euthermic or at least a core temperature more than equal to 36 degree. Systolic blood pressure has to be more than equal to 100 millimeter mercury. No spontaneous respiration. These are the prerequisites. All must be checked. If you are missing anything or you don't think no, it is not there, then you cannot go to the next one. Now, examination all must be checked again. 9 number, people non-reactive to bright light. At least they may ask you what will be the size. 5 to 7 millimeter typically mid position. Corneal reflexes absent. Use both saline jet and tissue touch. Both the two things. It's not only you are just putting the light or something. So both you have to put some saline also. Eyes immobile, oculocephalic reflex absent, tested only if C-spine integrity is ensured. 12. Oculovestibular reflex absent, 50 cc of water in each ear sequentially. 13. No facial movement to noxious stimuli at supraorbital nerve or temporomandibular joint compression. Absent snout or rooting reflex in neonates. 14. Gyre reflex absence, globed index finger. You are using your globed index finger to the touching the posterior pharynx. Cough reflex, again, you are actually doing the tracheal suctioning at least 2 passes. 2 times you have to do. Then only will say that cough reflex is absent. 16. No motor response to the noxious stimuli in all 4 limbs. Triple flexor response is most common spinal mediated reflex. Now, after all these things examination, go for the third stage, that is the apnea testing. Here, you have to maintain your hemodynamics. BP has to be more than equal to 100, PaCO2 35 to 45, PaO2 more than equal to 200, and patient has to be maintained on this PaO2 or FiO2 with a PEEP of 5 centimeter water. If not, consider again, you can do recruitment maneuver just to increase your PaO2. Then you go for disconnecting the ventilator, provide oxygen via an insufflation catheter to the level of the carina at 6 liter per minute, or you can attach a T-piece with CPAP at 10 to 20 centimeter water and resuscitation bag. You can just attach one resuscitation bag and connect here. Spontaneous respirations absent. ABG done 8 to 10 minutes, patient reconnected to the ventilator. If you are getting PaCO2 more than equal to 60 millimeter mercury or 20 millimeter rise from the normal baseline value, or apnea test is aborted because of some other problems, then you go for the confirmatory ancillary test, that is EEG or the blood flow based studies. And the documentation, time of death, use time of final blood gas result, or use time of completion of ancillary test. So the four things you have to do, then only your work is complete in the the brain death. This is a sample. Again, I am just highlighting here. What is the time? Initial PaCO2, final PaCO2, apnea test, adjunctive neurodiagnostic testing test result, declaration of death by neurologic criteria, date, time, physician signature, 1, 2. If it is having like no examination 1, examination 2. So you have to write it. Clear? This is again the same thing, but yes, in the examination, if you are confused, you don't have time to write, you can just make this type of algorithm flowchart based. What you are actually going to do and how you are going to reach to the conclusion. And these are two very good critical synopsis about brain death declaration. So just remember, you can read these things and in your leisure time. And this is editorial and this is review article. Now, the next question, I know it is very extensive, but yes, this is one of the important questions, the organ donor management. Now, in the organ donor management, before that, you need to remember the organ donation types are living related, living non-related. In living non-related, it is brain death and cadaveric donors, we all know. Now, commonly donated organs, kidney, liver, lung, cornea, heart, pancreas, lung, and skin. Clear? Cadaveric donors are major source of organs and tissues. Now there are again one other classification of organ the donor or the donation type is brain death and DCD. DCD is donation after circulatory death, DCD. We will be discussing that also. Now coming to the organ donation type, there is another organ donation. Almost everywhere organ donation is voluntary. Two voluntary systems include, one is opt-in, one is opt-out. Opt-in, when you are actually giving consent that if you are suffering something, then you are going for the organ donation. Opt-out is, try to remember, where anyone who has not refused is considered as a donor. Are you getting it? If you have not filed anything, your attorney has not done anything, your will has not written anything, you are actually opt out. That means if anything happens to anyone, he will be eligible for organ donation. But in India, we have the opt-in system where we have to write in our will or somewhere else that yes, if something happens to me, I will be subjected, or please consider me for organ donation. But Western countries, they go for the opt-out system. So any patient, any person who is having road traffic accident, brought to the ICU, there is no such family member, so automatically that person is in the opt-out. That means you can go for the organ donation part. Now, coming to the pathophysiologic changes, what is the pathophysiologic changes that happens so that at least you are actually going for the organ donation and the patient is in brain death? Neuronal injury normally happens. There is neuronal swelling and edema inside your brain. There is increased ICP, and as a result, what is happening? Decreased intracranial blood flow. Your ICP is more than your MAP, and that would be again exacerbating your neuronal injury. So this is a vicious cycle. So pathophysiology of brain death. This is the pathophysiology of brain death. And as a result, what will happen? There would be a catecholamine storm will happen, because there would be secretion of all the cytokines and the whatever remaining the catecholamines will be there, that would be immediately surge will happen. Now there would be some or other hormonal deficiency from the posterior pituitary, from the anterior pituitary, from the hypothalamus. As a result, there would be low vasopressin, thyroid dysfunction, insulin level, low cortisol level, and all these things would be precipitating hemodynamic instability and metabolic failure. There occurs one the organ crosstalk. As a result, what will happen? The CNS is right now affecting or having a crosstalk with the systemic organs, as a result of the inflammation that is happening in the brain. So the cerebral systemic inflammation, and all these things should be having deleterious effect on the potential organ donor. That means if I am not taking care of my patient who is brain dead, automatically from the brain there occurs a release or surge of the cytokines, the inflammation, the hormones that would be affecting liver, kidney, lungs, heart. So if I am thinking to take these organs out for the organ donation, but I am not actually putting my effort to preserve, so there would be deleterious effect on these organs. So the viability, the harvesting will not be so successful in the recipient body. So that is the reason why we need to take utmost care if you are actually having a brain dead patient and we are taking too long time to take all these organs to harvest in the recipient. Now, what are the immediate steps if you are suspecting or you are confirming that this patient is brain dead? Do not discuss organ donation with the family. This should be done by a separate organ procurement team. The examiner would try to confuse you that you have actually declared that this patient is brain dead. Now, you are calling this family relative to discuss for organ donation. How you are approaching? So the question is itself wrong. So you cannot call the family relative to discuss about the organ donation. By the that if you are actually going forward about the organ donation discussion, the examiner would get to know that you are actually violating the principle of making two teams. The clinical team is different, the organ procurement team is different. So you do not know. Your ICU, your hospital, or wherever you are practicing, you are not following the right pathway. Now, the family should be informed that the patient has died with appropriate explanation of brain death. So that you have to explain. So that you can do. Now, the challenge is right now here that you have to identify the potential donor, that yes, this patient is brain dead and also a potential donor. Now, the brain death determination has to be done by you. Again, there are certain challenges that also you have to take utmost care. Then you have to screen the donor for the organ harvesting or the organ procurement. So again, you have to send some samples, the test report will come. Now you have to approach the family with your team or with your designated organ procurement team, and then authorization from the family. So everything has to be done in sequence. So it's a difficult task if you are not having a proper team and their assignments are not being done in a very proper way. Now the priorities here as an intensivist, you have to early identify that this patient is a potential organ donor, establish rapport with the family early, non-coercive discussion with family regarding opportunity to donate. You cannot force, you cannot start initiating the discussion that yes, you should go for organ donation. No, then before that if you are actually discussing and then you are going for organ brain death declaration, the family relatives may create a problem. This is something relate coming in their family counseling part also. They would get some idea or hint that you are actually pushing the person for the organ donation. That's why you are so eager to go for brain death declaration. Now, as an intensivist, you should initiate tissue typing. Again, this is your job only. Organ function testing, LFT, RFT, or whatever blood test you are sending, the viral markers, the infection markers, sepsis panel, that you have to go for checking. Now, you have to send some test also, do some test at the bedside, echocardiography, biopsy, CT, ultrasound, bronchoscopy, blood test. Maintain the extracerebral physiologic stability because the intracerebral is already gone because there is no blood flow. But still the body is able to pump blood to the various organs, and those organs are actually your target. You are actually trying to get the liver, the kidney, the lungs. So that physiologic hemodynamic stability you have to ensure. Facilitate family time at the bedside and ensure the aftercare of the donor family. Once the organs are also taken out, you have to take care of the family. So bereavement service, the post organ donation care has to be also given by you. If you are writing all these things your answer paper or you are answering in the viva, definitely the examiner would be very happy that yes, you have a proper the thinking process in your mind. Now The role of intensivist in the care of potential brain death to maintain the hemodynamic stability, diagnose neurologic death, preparing the family for the devastating news, counseling the family for end of life care, implementing policy protocols for the option of organ donation, communication with transplant coordinators, organ procurement team, and family members. So you are the fulcrum of the organ donation process, starting from the brain death till the organ harvesting. Now, what are the management of organ donation patient? I am dividing in these headings. One is maintain the extracerebral physiologic stability in the form of ventilatory, and all the things that you do for any patient, you have to write: oxygenation, lung protection, normocapnia, head up position, bronchoscopy if needed, chest physiotherapy. Circulatory. Initially, there would be sympathetic surge. So you will get hypertension, dysrhythmia. But then after some time, when the ICP is rising, and then your homeostatic mechanism in the hypothalamus pituitary is actually not working, you will get hypotension. So in that, it can be neurogenic shock, hypovolemic shock, cardiogenic shock. So the treatment as per the shock: fluid, vasopressors, inotropes, antiarrhythmic drugs. You should have your proper hemodynamic monitoring. Now, coming to the neurologic, patient will be going into normothermia because your hypothalamic pituitary axis is affected here. So here you have to go for whether you are actually trying to stop the cold fluids exposure. If the patient is hyperthermia, you have to use the cold fluid. If hypothermia, your warm fluids exposure has to be taken care of. Loss of shivering will be there, decreased metabolic rate would be there. So you have to go for external warming, humidification. Now, the endocrine or metabolic, again, loss of hypothalamic pituitary axis. So you have to supplement with steroid, high dose steroid, and T3 hormones, thyroid. Usual supportive care: glucose control, venous thromboembolism prophylaxis, correct electrolyte, and coagulopathy, because the DIC is again one of the complications after happening in the brain death patient. Then finally, facilitate family time at the bedside, ensure aftercare of the donor family, and already we have discussed. Now let's go in depth. General care will be same, just like any ICU patient. So you can write one box about infection control, hand hygiene in patient position, bronchial toilet, eye care, NG tube feeding, arterial and central venous line. Monitoring, all the monitorings that you do for any patient: ECG, hematocrit, RBS, urine analysis, BUN creatinine, electrolyte, LFT, coagulation profile, ABG, blood grouping, hepatitis markers panel, and then CMB, IgB, and IgM. General resuscitative principles I have already told, similar to any patient receiving high quality supportive care. Then resuscitation may be tailored slightly to preserve the function of the organ for donation. If it is lung which is planned for the donation, organ donation, so you have to take utmost care of the lungs, because that is the precious organ that would be harvested on the other receiver or the recipient. Now, don't think about something which normally takes few days to develop. Like some people say, don't use antibiotics because if you are using broad spectrum antibiotic, that would cause C. diff infection. Look, man, you are only going for the organ donation maybe in the 6 hours or 12 hours. What will happen if you will get a single dose of antibiotic? How come that would be creating or resulting in C. diff infection? Sometimes people the argument would be for the high dose steroid, that it would be resulting in steroid induced myopathy, neuropathy. Again, the same principle. You are only giving it for short duration, so it will not result in the steroid induced myopathy or neuropathy. Now, the goal for maintenance: medical management, I have already explained. Management of hemodynamics, I have already explained. Then take care of the transient autonomic storm because of the sympathetic hormones, the secretion. Maintain all the organs, and always use a rule of 100. Remember this rule of 100. What is this rule of 100? Systolic blood pressure more than 100, urine output more than 100 ml per hour, PaO2 more than 100 millimeter mercury, hemoglobin more than 10 gram per deciliter or 100 gram per liter, blood sugar more than 100 milligram per deciliter. So rule of 100. If you remember, you can write all these things in your exam. Hypovolemia, yes, IV fluids. If you are looking for the lung transplantation, then try to give little bit of less fluid, because all this fluid will be congested in your lung. And when you are actually taking the lung out, it will not be a good lung to be transplanted. So check for volume expansion, hormonal replacement, and vasopressors ionotropes for the hypovolemia or hypotension. Corticosteroids, the reasons I have explained. Again, the steroids also can reduce the inflammation, so thereby improving the graft organ functionality. High dose 1000 milligram IV methylprednisolone daily. You can also give 15 milligram per kilogram. So a 70% kilogram person, it will be coming to 1 gram methylprednisolone. Then management of DI. DI is normally happening in the brain dead patient. Now it commonly occurs, but it is not that always you will be getting diabetes insipidus. So your function, your when you are actually targeting how you are going to manage the diabetes insipidus, your target should be bringing the sodium back to the fairly normal level. You are not targeting the urine output. Why it is important for the organ donation part? If you are not bringing the sodium level to the normal level, hypernatremia has detrimental effect on the liver. So if you are planning to go for liver transplantation, hypernatremia occurring due to diabetes insipidus is going to actually harm your liver in your your organ donor. So that's why you have to take care of the DI. Now, how will you diagnose that this patient is in DI post your brain death? Because of the copious dilute urine production, we have already discussed this. Urine output would be 250 300 ml per hour, but the differential diagnosis also you have to exclude polyuria due to hyperglycemia, hypothermia, or you are using some medications that is actually causing the diabetes insipidus. If you have any doubt in presence of hypernatremia and hypotonic urine, your urine osmolality will be less than 200 milliosmolar per liter, or urine specific gravity would be also less than 1.005. Clear? Now, treatment should not be delayed, just waiting for these reports. If you are thinking you are getting the urine output to be very high, there is history of the traumatic brain injury, brain death has been declared. So think that yes, this patient is in DI. And the treatment would be option number 1, desmopressin. Nasal desmopressin 2 to 4 microgram, Q6R to Q8R. We all do it. But in examination, you have to mention this thing, the treatment option, just put the one puff. Now, advantage, easy to do, doesn't tie up IV line. So you don't need one IV line for this type of thing. So just immediately press the inhaler. Disadvantage, what is a disadvantage? Desdido arginino vasopressin, this is the desmopressin, will take hours to wear off if hyponatremia occurs. So you have to be very cautious, know how many times you are actually using it. If you use it more, so patient will go into hyponatremia. That would be again detrimental. Now the treatment option 2, vasopressin infusion. It is again congener of your desmopressin. Now very low doses of vasopressin are sufficient to reverse the diabetes insipidus, just 0.01 unit per minute or lower. Now these vasopressin infusion with this much of dose will not have much effect on the hemodynamics. So don't worry about that would shoot up your blood pressure or something like that. And useful again, it would be additional advantage in patient who are actually having hypotensive episodes, and you can go up to 0.04 unit per minute. Advantage, you can titrate, which is not there in desmopressin. Desmopressin you have to just use at as inhalation. So if you are using it's inside gone means gone, but here as it is infusion, you can stop immediately and the effect will be wearing immediately. Now improvement in the cardiac function. If the patient is in poor cardiac function, the cardiogenic shock, the treatment is not primarily inotropes. The treatment would be thyroid hormone supplementation, because here the thyroid is right now following a brain death, a sick euthyroid state frequently occurs. When you will say it is a sick euthyroid state, when you are getting elevated level of inactive reverse T3 and low level of active T3 and normal level of T4. And this exogenous thyroid hormone is trying to improve your cardiac function and candidacy for heart donation. So if you are thinking to go for heart donation, definitely you have to go for thyroid hormone supplementation. And what are the hormones? Normally T3 is more effective, but we do not get in India T3. So maybe you can go for T4. If you do not have the IV formulation, go for the oral formulation also. But the bioavailability will be definitely a question mark. Clear? So this is about, and then the lung function. They say if you are going for the lung or the organ donation, so you have to avoid subclavian vein, central line, because again you are going for the lung to be transplanted. So anything happens in terms of the pneumothorax, so you are actually harming that lung. So why to put the subclavian vein to make it more problematic? Now, bronchoscopy you should do to evaluate the candidacy for lung donation if there is some infection in the donor. So you have to exclude that. Avoid performing bronchoalveolar lavage. Why? Because if you are actually doing lavage with 20 ml, 30 ml, 40 ml water, so it is actually retaining in the lungs. So when you are actually taking that lung to a recipient, you are actually giving a congested lung to the recipient. Better airway pressure release ventilation has been shown to improve the candidacy for lung donation and avoid volume overload. Now the temperature management I have already discussed. You have to go for external warming. Empiric antibiotic you can give. Don't think about all these complications of antibiotic. Now, just at the last, I want to highlight Kerala is the one state that has actually started with SOP for brain death certification. If Sri Hari is here, he must be knowing. As per the January 2020 government orders, doctors get the right to decide whether a patient certified as brain dead needs to be taken off life support, for which the family's consent won't be required. So this is something to the next level. But yes, the nitty-gritty has to be seen. Now, the last part I will be finishing maybe in 10 minutes or 5 minutes, DCD, because that is again one question, and Darshan has specifically told me to discuss about modified Maastricht classification. The STEM, what is the definition? What are the terminology? Why there is increase in the DCD across the globe? What are the categories? What is the criteria? What are the absolute contraindication? The pathway for control DCD? What is the meaning of warm and cold ischemia time? Process of the treatment withdrawal. In the Indian context, what is the current position of DCD? What is the conclusion? Now, this is something I got in my training also. I was part of 4 DCD in my training period. So you can see this person are right now getting out of the ICU just for the sake of organ donation in the OR. And all the nurses, the doctors, the hospital staff are paying last tribute to this person, and the family is at the back going along with this person to the OR, because you are actually withdrawing the life sustaining therapies and taking this patient to the OR, so that immediately you are taking the organs out and you are putting that person's organs in some other person. So this is something, no, respect for the as a the appreciation. Everybody is standing by the side of the corridor to just show the last respect to this person who has been one of the organ donation after the death, cardiac, the DCD. Now, why this DCD is coming into limelight? Because everybody knows that shortage of organs is the most important barrier to the expansion of the transplant therapies across the world. Now, whatever right now we are doing till now is based on the death using the neurology criteria, brain death. But in recent decades, due to the improvement in the neurosurgery, neurointensive care, now the patients are not going for the brain death declaration. So there has been renewed interest in the donation from persons whose death has been determined using circulatory and respiratory criteria. That means post cardiac arrest, patient on ventilator with advanced age for long time, not showing any improvement. So these patients are actually potential donors, where if you are taking the tube out, these patients are good organ donors. Now, but the problem is the warm and the cold ischemia, because if you are taking the tube, the organs out, or you are taking the tube out, you are stopping the circulation at that time. So till the time that organ is taken out, again implanted in the recipient, so there is a ischemia time happening. So this is the warm and the cold ischemia. So that is the problem. If you are taking care of that part, maybe with a proper well organized DCD pathway. So maybe this DCD is the need of the hour and the future of organ donation. So that's why when we conducted one organ donation in the Indian Society of Organ Transplantation conference last month only in Ahmedabad, so we have got so good response from the all the attendees, the nephrologists, the organ transplant physicians, as well as the intensivists. Now, the terminologies, there are so many terminologies you will be getting. One is the donation after cardiac death, donation after brain death. Then that has been changed to donation after circulatory death. Why the difference between donation after cardiac death and donation after circulatory death? Because these patients are also being utilized for the heart transplantation. So if you are actually giving nomenclature cardiac death, that means the heart is dead. So how the heart is actually getting again transplanted to somebody? So that's why the cardiac death is not a proper word. Rather, donation after circulatory death is more appropriate. So this is something, but before it was heart beating donor, non-heart beating donor. Before the first terminology was non-heart beating donor. Now the basic difference, I think you all know, brain dead donor and then circulatory death donor. Clear? But the organ retrieval has to stop as soon as possible, start as soon as possible after death has been determined, and preferably within next 60 minutes, because that would be improving the organ viability. We all know what is the reason for DCD across the globe to increase. The categories. This is again the question that maybe examiner would be asking you. What is the difference between uncontrolled? What is the difference between controlled? Uncontrolled, when cardiac arrest is occurring suddenly and unexpected. So you are not ready. Your team is not ready. So that is uncontrolled. Any cardiac arrest happening unexpectedly in your ICU. So that means the time taken to retrieve the organs and put them in the ice, that is the warm ischemia time, that is much longer, because you are not ready, your team is not ready, and your organ transplantation team is also not into picture. So that would be happening the organ transplantation here in uncontrolled. If the organ transplantation team and facility, the organ retrieval perfusion is in house, then only you can go for organ donation in uncontrolled variety, otherwise it will not be effective. Now the opposite part is the controlled. What is the meaning of control? Where you are actually deciding when you are taking the tube out. That means elective withdrawal of ventilation in an end of life situation leading to cardiac arrest. That means the counseling has been going for like 2 days, 3 days. The patient is not showing any improvement, and you are already prepared that at 12 noon as a team we will be taking the tube out. So that is the controlled. That's why it is controlled DCD. Here, what is the difference? Warm ischemia time would be much less, because already there is another team which they are ready with gowns on, with hands gloved in the OR, ready to take the organ out. So you can take the tube out in the ICU, or sometimes you can bring the patient to the OR. In the OR, you are taking the tube out. You are going for the window period where 2 to 5 minutes you are waiting. Then officially the patient is dead, and then immediately the organ donation team or the transplant team is taking the liver, lung, or whatever maybe, and implanting in the recipient. So that is more control, better suited. Spain, France, Italy, they use organs from the uncontrolled donors. But Netherlands, UK, they are the countries where they are going for the controlled. In the Indian context, hardly any center is right now doing. But yes, it is right now slowly, gradually picking the pace. PGI Chandigarh, they have done a series of patients of DCD. But yes, still a long way to go. This is the modified Maastricht criteria. Maastricht is one city in the Netherlands. So that is updated in 2013. And they have divided into category 1, 2, 3, 4. And you can see this is as per the controlled or uncontrolled. So category 1 is found dead, out of hospital, in hospital. Category 2 is uncontrolled. That means witnessed cardiac arrest out of hospital, in hospital. Category 3 is the controlled. That means you are taking the tube out, or like stopping all the ventilatory support, or like the vasopressors, whatever life sustaining therapy. So that is the most important primary mode of DCD. Category 3. And category 4 can be both uncontrolled control when cardiac arrest after brain death determination. So patient is in brain death right now and then going for the cardiac arrest. So these are the controlled and uncontrolled. Just remember what is the difference between controlled and non-controlled. Now, what is the pathway for controlled DCD? So they may ask you, or you can just remember what is happening, the process here. Potential recruitment review, critical illness is there, end of life decision is decided, donation request is there. You think that this is a DCD potential? Yes, then confirm the DCD pathway, screen, match, organ allocation, end of life care plan agreed. You are going for pre-preparation hurdles, whatever is like there. Now, initiation of end of life care, withdrawal of life sustaining therapy is one step. Then patient is going for cardiorespiratory arrest. Then you will be waiting for 2 to 5 minutes, no touch period. Then you are declaring the death within the appropriate time frame. Go for organ procurement. If no, end of life care and whatever maybe, if the patient is not in the stage to go for organ donation, that also can happen. Clear? What are the organs eligible? In controlled DCD, kidney, liver, pancreas, lung, and heart. In uncontrolled, as the uncontrolled is there, no, so you don't have the capability or capacity to maintain, preserve the heart, because the heart is right now arrested finally. So heart is excluded from the uncontrolled, but all other organs you can go for the transplantation. This is the basic difference. In controlled, you can go for the heart transplantation also. Clear? What is the warm and cold ischemia in the DCD? So you are going for the withdrawal of life sustaining therapy. So the oxygen saturation is right now dipping. SpO2 is less than 25. And the blood pressure is also going down. SPP is less than 60, less than 50, less than 35. Patient is going into circulatory arrest. Then no touch for 2 to 5 minutes. You are declaring death. Then patient is put, the organ is put in the cold perfusion. So there starts the cold ischemia. Then you are going for the reimplantation in the recipient. Then recipient warm ischemia will happen. There would be some time when the reperfusion would be happening to the organ which have been implanted in the recipient. Clear? So warm ischemia, cold ischemia. Cold ischemia once starts after that declaration of the death, and you are starting the cold perfusion and then reimplanting. So this is the cold ischemia. But before that, it is all warm ischemia. So you have to cut short the warm ischemia time so that you can start with the reimplantation. This I have already discussed. What is that WIT? There are certain challenges. Just remember, the examiner may ask you, what do you mean by normothermic regional perfusion? What is normothermic regional perfusion? Just to tackle the unique challenges. This is one method where you are restoring blood flow to the organs after circulatory death. So now the patient is arrested. You are taking the tube out. Patient is completely dead. There is no blood flow. So in the meantime, you are actually shifting the patient to the OR, taking the organ out. You have to maintain the blood flow to the other organs. So that would be done by normothermic regional perfusion. You are actually allowing that functional assessment and maintaining the perfusion to the individual organ. This is also one method. Now, ex situ machine perfusion. What is that? Post explantation. You are taking the organ out. Now the organs are connected to the perfusion device. So there is one organ perfusion device that would be supplying oxygenated blood to that specific organ that is planned for the implantation at normothermic or hypothermic temperature. So this approach not only preserves, but also you get some time to also find, assess, and potential repair if the organ is also having some problem, liver is having some problem. So you can at least have some time to test the viability of the liver before going for the liver transplantation in the recipient. Now, organ care system, these are some portable devices that maintain these organs in a near physiologic state during transport, reducing the cold ischemia time. And you can take the organ from one hospital to one setup to the other setup, maintaining the viability and better assessment before the transplantation. So not going into detail, but yes, you need to can continue with heparin, steroids, vasodilators, reduce the withdrawal of the time also in the OT. Your team has to be ready to get all the organs immediately. And post-mortem reperfusion, I have already told, like liver, early tissue typing, so that you should not waste your time just for going for the tissue typing and other basic things. So your time would be maintained and you can save your time. These are some of the functional warm ischemia time for the DCD organ retrieval. Kidneys 120 minutes, liver 30 minutes, lung 60 minutes, pancreas 30 minutes, something around in the range of 30 minutes or 60 minutes. Treatment withdrawal is almost similar thing. Decision making independently before consideration of organ donation. No member of the transplant or donor coordination team should be involved in the decision making. Timing of the treatment withdrawal. Retrieval team has reached a hospital. All preparation made in the theater. All possible steps taken to recognize the need of the donor and the family. Location, OT, that would reduce the extent of the ischemic injury, but compromise other aspects of your. Ensure family friends have access to the patient, religious or spiritual needs are met with, and time of death after 5 minutes of continuous cardiorespiratory arrest. Normally, this is 2 to 5 minutes. I showed you. So this is no touch period. So at least they will be giving some time so that all the the flow to the organs as well as the basic vitality will be stopped. Or mostly in Indian context, I have already explained, lack of clarity in the law, no practice of withdrawal of support in end of life situation till date. But yes, as per the new law, Supreme Court has actually allowed the death after declaration, the circulatory death. So that has started been attempted in India, but again only be used in unanticipated circulatory arrest. And in conclusion, organ and tissue donation should be a routine part of end of life care in ICU and emergency department. Both it should be donation after the declaration after brain death determination and donation after circulatory death. And DCD allows the family the option to meet the wish of a dying relative to become an organ donor. And definitely DCD schemes has the potential to increase the number of transplantable organs donated by dying ICU patient. This is again organ donation after circulatory death. This is one article you can take 2019 where you will be getting the current status and the future potential. And there is in our ISCCM critical care update 2019, you will also get one chapter about DCD. Thank you very much. I know I am been very comprehensive and in detail about these three topics, but these are very close to anybody. So I have taken my all time to prepare these presentations. Any questions at this time? I will be happy to answer. I know it is very exhaustive, but I thought you should not be reading after this class. So that's why I have posted at 3 o'clock that please don't miss this one. The concept have been cleared. So if it is no more questions, all the best of you guys. I know you are all doing great, but please involve in the discussions where you will be getting to know in 1.5 hours of non-stop class. I try to cover up all the things related to brain death. Thank you. Darshan and Niharika, whoever wants to. Yeah, Bhubaneswari. Yeah, please. Yeah.
Hi, good evening, all. So, we'll be dealing with the last topic of the day, that is steroids in ICU and CERC. Both are important exam questions which has been asked in the previous year question papers. So I had covered the basic clinical physiology as well as the pathophysiology in both. I don't think anything else is required if you go through the slides. So let us start with steroids in ICU. You can see my screen. One of the students can answer.
Yes, ma'am.
Yeah, okay. So coming on to the basic clinical physiology, corticosteroids, which is the product of cholesterol metabolism, happens in the zona fasciculata of the gland. The production is highest in the morning and lowest during the night while sleeping. Under non-stress conditions, the adrenal gland can produce around 20 mg daily in adults, but whereas during a stress situation, the production can go up to 150 to 200 mg. And that will be like equivalent to the circulating level doses of 20 to 45 microgram per deciliter. So coming on to the physiology, we know that endogenous cortisol production by the adrenal gland is controlled by the hypothalamic pituitary adrenal axis, and it occurs in a diurnal and circadial pattern every 24 hours. So the corticotropin releasing hormone is released from the hypothalamus and acts on the anterior pituitary to release the adrenocorticotrophic hormone, which stimulates the cortisol production and release from the adrenal gland. Even exogenous adrenocorticotropic hormone results in an increase in the serum cortisol. That is what we call it as synactin test or the ACTH test. So this is the basic physiology of cortisol production. Mineralocorticoid. The primary mineralocorticoid is aldosterone, which is produced in the zona glomerulosa, which takes care of the sodium and water balance. And this release is primarily controlled by renin-angiotensin-aldosterone system and serum potassium concentration. Mineralocorticoid, and it has the similar quality, structural similarities like corticosteroids because they are derived from the cholesterol component. So steroids can be classified based on their origin, like endogenous steroids like cortisol, aldosterone, testosterone, the sex steroids. It could be synthetic steroids like prednisone, methylprednisolone, fludrocortisone, ethinyl estradiol. By potency, it can be low potency, medium potency, and high potency. Either by duration, it could be short acting, that is 8 to 12 hours, intermediate acting, that is 12 to 36 hours, and long acting steroids, that is 36 to 72 hours. This is how a brief classification of corticosteroids has been done. So this is based on the duration of action. You can see that the short acting steroids are hydrocortisone and cortisone acetate. Intermediate acting ones are prednisone, prednisolone, and methylprednisolone. Long acting ones are dexamethasone. And if you see in the glucocorticoid, dexamethasone has no mineralocorticoid activity, and hydrocortisone has the highest mineralocorticoid activity. When you see fludrocortisone, it has no it has very minimal or no glucocorticoid activity, but it has highest mineralocorticoid activity. So based on the duration of action, the half-life has been defined. So a brief word about each steroids. So hydrocortisone, which is equivalent to the natural cortisol, which is in its active form, it does not require any conversion. So it has the highest mineralocorticoid activity also. And cortisol, which is the natural steroid, active form, it has mineralocorticoid activity, which is the primary natural glucocorticoid. Cortisone, where there is chemical modification at the hydroxyl group at C11 place, where it is converted to cortisol. So it has a lower glucocorticoid potency, but it also has mineralocorticoid activity. Prednisone, again changes at C1, C2 levels, where it is converted to prednisolone, where it has higher glucocorticoid activity. Methylprednisolone, where methylation happens at C6, which is the active form. It has enhanced glucocorticoid activity, less mineralocorticoid activity. Dexamethasone, which is the highest potent highest potent glucocorticoid activity, but no mineralocorticoid activity. And fludrocortisone, here the changes at 9 alpha position, where it has highest mineralocorticoid activity and minimal glucocorticoid activity. Coming on to effect of corticosteroids on the organ systems. So coming on to metabolic effects, it can cause hyperglycemia, muscle catabolism, lipolysis, and osteoporosis. Coming on to immunosuppressive effects, it reduces the immune function, impaired wound healing and infection risk. Neuropsychiatric effects, it can cause euphoria, insomnia, psychosis and depression. Coming on to cardiovascular effects, it can increase the cardiac output, it can increase the catecholamine sensitivity, which plays a major role during the septic shock. Respiratory effects, it can cause bronchodilation and reduce mucosal edema, which is why we use it in small airway disease exacerbations. And coming on to fluid and electrolyte, it causes hypernatremia, hypokalemia, fluid retention. Coming on to musculoskeletal effects, it can cause muscle weakness and avascular necrosis. It can cause suppressed adrenal laxus. And other effects could be fat redistribution, peptic ulcers and dependence. So adverse effects, so HPA axis suppression, physical appearance changes, insomnia, increased appetite, hyperglycemia, muscle wasting. It could cause reduced bone mineral density, increased bruisability, atrophy of the skin, immunosuppressions, cataracts, glaucoma, weight gain and psychiatric disturbances. So this is the brief introduction about corticosteroids. So let us discuss the important part, that is the role of steroids in ICU. Let us go system wise. So coming on to respiratory, the role in ARDS. So how are we going to approach this? So we are going to see some of the strong evidences, that is from the meta-analysis, systematic analysis or some of the named landmark trials which has used this steroid in the condition. And finally we'll derive a conclusion about whether we could use or not. So the first is role in ARDS. So this table shows us some of the significant trials which has used steroids in the ARDS. So earlier in 1987, there was one trial called Bernard trial where they used methylprednisolone every 6th hourly for 24 hours in ARDS patients, where there was no difference in mortality, but there were more complications like hyperglycemia. In 1998, there was Meduri et al. Where they used methylprednisolone in a tapering dose for ARDS, where they found that there is improved lung injury score and improved ICU and in-hospital mortality. In 2006, there was a study by Steinberg et al. Where they used methylprednisolone in a tapering dose over 14 days, where they did not find any mortality benefit. And Meduri et al. Again conducted a study in 2007 using methylprednisolone for up to 28 days, where they found that there is improvement in the lung injury score and duration of mechanical ventilation and ICU length of the stay. There was one trial called DEXA ARDS trial in 2020, where they used dexamethasone for 5 days and then 10 mg per day for up to 10 days. It was stopped due to the low enrollment, and they found that there was improved ventilator free days at 28 days. And in 2021, there was a meta-analysis wherein the one problem was many of the patients were COVID-19 patients, where they found that the use of steroids in ARDS in COVID-19 patients and in a normal ARDS, they found that improved mortality, ventilatory free days at 28 days and improved oxygenation index. Coming on to role in severe pneumonia. So earlier in 2005, Kanfa Lonieri had conducted a study where they used hydrocortisone, where they found improved mortality, hospital length of the stay, progression to the septic shock and improved oxygenation. But followed by a few of the studies showed no difference in 60-day mortality, like studies done by Fernandez, Torres, Meduri in 2022, where they did not found any difference in 60-day mortality. There was one study recently in 2023 by Dequin et al. Called Cape COD trial, where they used hydrocortisone 200 mg for 4 to 7 days and then tapered in severe pneumonia, where they found improved 28-day mortality. So a specific note on COVID-19, there was a recovery trial in 2021 where they found improved mortality benefit. Decune 2020 in COVID-19, where they used hydrocortisone 200 mg daily, because the study was stopped early because of the recovery trial was released. In 2020, there was one more trial done by Tommazzini in COVID-19 patient, where they used dexamethasone. So overall, there was improved mortality with the use of dexamethasone in COVID-19 patients, as per recovery trial evidence. So there was one focused update in 2024, which I had uploaded in the drive. You can see through that in a critical care journal, where they have mentioned the specific dose for ARDS and severe community acquired pneumonia for the use of corticosteroids. So yearly ARDS, dexamethasone uses around 20 mg IV daily for 5 days and then 10 mg IV daily for 5 days until extubation. If yearly ARDS within 72 hours, then you start methylprednisolone 1 mg per kg IV bolus and then slowly in a tapering dose till the extubation. And unresolving ARDS, 7 to 21 days, where you can use steroids as the initial methylprednisolone dose bolus followed by infusion and then taper till extubation. Whereas in severe community acquired pneumonia, the dose has been given as hydrocortisone 200 mg IV once and then infusion for 7 days. Methylprednisolone, it will be 0.5 mg per kg IV for 12 hours for 7 days. And then you can also use another regimen, methylprednisolone 40 mg IV bolus followed by a tapering dose as in continuous infusion and oral dose even after ICU discharge. So overall, in ARDS, when there were some of the review articles showed that multiple randomized control trials in COVID and non-COVID patients, corticosteroids reduced the 28-day mortality, and longer courses were beneficial than the shorter courses, but the only problem was problems with the hyperglycemia. Whereas in community acquired pneumonia, overall the study showed no mortality benefit in less severe community acquired pneumonia, but more severe community acquired pneumonia as per the CHESS criteria. There was some mortality benefit. So the conclusion is, in ARDS, yes, there is the mortality benefit even in COVID and non-COVID patients. In community acquired pneumonia, in severe community acquired pneumonia, yes, there is mortality benefit, but not in less severe community acquired pneumonia. This is the conclusion as per multiple randomized control trials. And the efficacy of corticosteroids in ARDS, now there are several phenotypes of ARDS, right? Inflammatory, hyperinflammatory, hypoinflammatory. So it depends on what phenotype of ARDS we are addressing and what is the timing and timing of ARDS we are initiating, what dose of corticosteroids we are initiating. So all that matters when it comes to ARDS. So coming on to bronchial asthma. So as per GOLD 2024 guidelines, in COPD exacerbation, prednisone 40 mg per day to be given with a maximum dose of maximum for 5 days. In asthma exacerbations, as per GINA guidelines in 2024, prednisone or equivalent 1 mg per kg per day for 5 to 7 days. Coming on to airway edema. So there was one systematic review and meta-analysis released in 2023. Which was combining all the randomized control trials, where I will tell about the results of that study in the next slide. So coming on to airway edema, the most common complication of endotracheal intubation is laryngeal edema, where it can lead to post-extubation stridor or it can lead to subsequent re-intubation. So the dose indicated in airway edema is that dexamethasone 0.5 mg to 2 mg per kg divided over 4 to 6 hours, started 24 hours before extubation and continued for 24 hours after extubation. Because dexamethasone has the highest anti-inflammatory effect, we are choosing dexamethasone. So this was that meta-analysis which I was telling you. In 2023, they have released a meta-analysis assessing the efficacy of corticosteroids, whether it could be methylprednisolone, dexamethasone, hydrocortisone, in preventing the post-extubation stridor and re-intubation in mechanically ventilated adults, where the primary outcome was to see how many patients had post-extubation stridor, and the secondary outcome was to see re-intubation rates. So they had used methylprednisolone, dexamethasone and hydrocortisone. So according to the study, methylprednisolone had better effectiveness compared to dexamethasone and hydrocortisone. And it was methylprednisolone 20 mg IV every 6th hourly for 24 to 48 hours before extubation. Dexamethasone 5 mg IV 6th hourly for 24 to 48 hours before extubation. So they found that both the steroids, dexamethasone or methylprednisolone, had reduced the post-extubation stridor and re-intubation rates. So the regimen is, suggested regimen is, pre-extubation methylprednisolone or dexamethasone should be given 24 to 48 hours before extubation and 24 hours after extubation. Coming on to pulmonary fibrosis. So as per guidelines, coming on to idiopathic pulmonary fibrosis, as per ATLS guidelines, corticosteroids is not recommended routinely. In acute exacerbations of IPF, we can use prednisolone 0.5 mg to 1 mg per kg per day, 2 to 4 weeks taper. And in case of connective tissue disorders, prednisolone 0.5 mg to 1 mg per kg per day and then taper as per response. And in case of hypersensitivity pneumonitis, prednisolone 0.5 mg to 1 mg per kg per day, 4 to 6 weeks, and taper to the lowest effective dose as per the clinical response. Coming on to pneumocystis pneumonia, this is recommended from CDC guideline 2004 to till recent articles in 2023, wherein pneumocystis pneumonia, the primary agents used are prednisone and prednisolone. The doses would be prednisone 40 mg twice daily for 5 days, 40 mg once daily for 5 days, and then 20 mg once daily for 11 days. So a total of 21 days. So an adjuvant corticosteroid therapy in severe PCP cases in HIV patients had significantly reduced mortality in severe cases. When they have hypoxia and severe PCP cases, there is significant mortality benefit. So there is improved survival rate and reduced complications such as pneumothorax and respiratory failure. But the risk is there is always a potential for increased opportunistic infections, especially in an immunocompromised patient. So as per studies, as per recent meta-analysis, adjunctive corticosteroids had a reduced mortality risk compared to the control groups. Coming on to role in resuscitation. So as we know, as per SSC guidelines in 2021, whenever a patient is having ongoing vasopressor requirement, we have to start in refractory septic shock, suggested to start when the noradrenaline dose is more than or equal to 0.25 microgram per kg per minute and at least 4 hours after noradrenaline initiation. And the mechanisms of the steroid use in septic shock is that it increases the number of receptor sensitivity, of course. It decreases the release of adhesion molecules. It increases the transcription of anti-inflammatory cytokines. It decreases the transcription of pro-inflammatory cytokines. It inhibits arachidonic acid. It inhibits the platelet activating factor. It prevents the neutrophil aggregation and inhibits the inducible form of nitric oxide and prevents complement activation. So overall, it has a role in improving the catecholamine sensitivity as well as the role in sepsis by reducing the inflammation and other cytokine suppression. So coming on to evidences, starting from Anane et al. In 2002, where they studied the effect of treatment with low doses of hydrocortisone and fludrocortisone on mortality in patients with septic shock, where they found that there was no significant effect of steroids on mortality in responders. That is in case of ACTH stimulation test in responders. But among the non-responders, low-dose steroids do reduce 28-day mortality and vasopressor dependence time. Followed by the Corticus trial, which was released in 2008, where they studied the hydrocortisone therapy in patients with septic shock, where they found that hydrocortisone did not improve the survival or reversal of shock in patients with septic shock, although reversal of shock was faster in those who received hydrocortisone. Coming on to the next trial, that is the HYPRESS trial, which was released in 2016, where they studied the effect of hydrocortisone on development of shock among patients with severe sepsis, where a continuous infusion followed by tapering dose of hydrocortisone did not prevent severe sepsis to septic shock progression within 14 days of treatment initiation when compared to the placebo. Coming on to adrenal trial, which was released in 2018, where they studied the adjunctive glucocorticoid therapy treatment in critically ill patients with septic shock, where they found that continuous infusion of hydrocortisone did not result in lower 90-day mortality. Steroid use actually led to more rapid resolution of shock, shorter inpatient ICU time, and lower incidence of blood transfusion, but there was no mortality benefit. Then came the Approaches trial released in 2018, where they again studied the hydrocortisone plus fludrocortisone for adults with septic shock, where they found that there was a hydrocortisone with fludrocortisone combination showed a mortality and a resolution shock benefit in Approaches trial. So this is a flow chart showing us starting from 1976 till 2023, the debate still goes. And in 2023, there was a meta-analysis done by Piraccio et al., where they compared 17 trials with individual patient data from all the previous trial, where they found no significant reduction in 90-day mortality of hydrocortisone compared to placebo, and no difference in secondary outcome except for vasopressor-free days. So overall, there is always a controversial study outcomes when it comes to steroid. But as per guideline, whenever the patient is reaching that 0.25 microgram per kg per day, per kg per dose of noradrenaline, you have to start steroid in refractory septic shock as per the guidelines. But the outcome benefit is controversial as per various studies. But the recent meta-analysis in 2023 says there is no mortality benefit, but definitely the vasopressor requirement, the vasopressor free days is better with steroids. That is the final conclusion. So there was one student who had asked about the tapering of the steroid in the group. So as per various evidences, I had put in a table for tapering the steroid dose, giving some justifications. So when it comes to HPA axis suppression, so standard dose of hydrocortisone 200 mg per day more or less mimics the physiological cortisol production during the stress. So when you use such a dose like 200 mg per day, then tapering may not be required when your use is less than 7 days. Okay, this is as per some of the guidelines as well as the recent, the trials which were studied on steroids. Coming on to shock resolution. So abrupt cessation of corticosteroids after 5 to 7 days showed no recurrence of shock or rebound inflammation in the randomized control trial. So if you had used for 5 to 7 days and the dose is 200 mg per day, then you need not go for tapering of the dose. Coming on to duration of the dose. As I told you, if it is less than 7 days, then you need not worry about tapering. You can just abruptly stop. If it is more than 7 days, then based on the clinical response, based on the how much suppression it would have caused on the patient, then you can consider tapering for prolonged therapy. Coming on to adverse effects, again when you have used less than 7 days and the dose of 200 mg per day, the adverse effects for steroid is less in case of randomized control trials. So the abrupt cessation will not cause any major impact on the effects also. So overall conclusion, you need not taper and stop if it is used for 7 days at least, and a dose of only 200 mg per day is used. So the risk of suppression, effect, shock resolution has no major impact. But if you had used a higher dose or a more than 7 days duration, then you may have to consider a tapering dose. So that is with respect to septic shock resuscitation. Now coming on to metabolic resuscitation. So we all know what is metabolic resuscitation. We use so many components like hydrocortisone, ascorbic acid, that is vitamin C, thiamine therapy. There has been so many trials as an adjunctive for sepsis aimed at addressing the mitochondrial dysfunction and oxidative stress, which is central to the sepsis pathophysiology. So even to this, there are various controversial outcomes in many studies, but there was a recent meta-analysis and a good study with vitamin C where it has no benefit for as an adjunctive therapy in sepsis. What about steroids? And most of the review articles had only a combined effect on metabolic resuscitation. There was no studies significantly for steroid on metabolic resuscitation. So as it is a combined thing only I could find, I have put in this gist of a table. In 2017, there was a study conducted by Myrick et al. We all know that where he had used hydrocortisone, ascorbic acid and thiamine, all three, where there was improved survival and vasopressor independence in septic shock. There was vitamins trial where they used a combined therapy versus hydrocortisone alone. There was no significant difference in 90-day mortality or vasopressor free days in both groups. Then came Orange's trial. Yearly HAD therapy was tried. There was a faster shock reversal was observed. And then came ACTS trial where they used all three therapy. There was no significant mortality benefit or improvement in organ function. Then came Victor trial where they used HAD therapy. There was no significant impact on inpatient mortality. And coming on to overall conclusion on metabolic resuscitation for steroids. Hydrocortisone can hasten the shock reversal and reduce the vasopressor dependency as we saw in septic shock resuscitation. And glucocorticoid and fludrocortisone combination may improve short-term and long-term mortality. This is as per the trial evidences. Coming on to synergistic effects, when you combine with ascorbic acid and thiamine, always had shown mixed results. One study showed good outcome, one study showed no good outcome. So there is no mortality benefit. Maybe for shock reversal, there could be some benefit. Coming on to safety concern associated with hyperglycemia, but there is no significant rise in secondary infection or adverse effects at appropriate doses when it comes to hydrocortisone. So you can use, if the patient is having a septic shock, when there is justification of shock reversal, you can use along with an as an adjunct also with other adjunctive therapies. Coming on to role in CNS. Coming on to CNS infections, of course we know when there is Streptococcus pneumonia, bacterial meningitis, to reduce the mortality as well as neurological complications, we use steroids. Dexamethasone 10 mg IV every 6th hourly for 4 days has to be administered before or with the first dose of antibiotics in cases of bacterial meningitis. Coming on to Haemophilus influenza, especially in children, it reduces a severe hearing loss in children, but no significant effect on mortality. It is more or less the same dose as in Streptococcus pneumonia. In Neisseria meningitis, there is limited evidence, but trend is towards the better outcome. So you can use dexamethasone 10 mg IV every 6th hourly for 4 days. But when it comes to Listeria monocytogenes, most of the review articles had said that it is not recommended and it is associated with worst outcomes and higher mortality. So we should not use it in Listeria monocytogenes. In tuberculous meningitis, of course, we have to use it. Has reduced mortality and complications across all stages and HIV statuses. So it is the same dose. In cryptococcal meningitis, it is not recommended. There is increased mortality and adverse effects with adjunctive steroid use. Coming on to herpes simplex encephalitis, no significant differences in clinical outcome, but as per the studies, potential benefit in reducing inflammation. Autoimmune encephalitis, yes, it is strongly recommended as a first line and second line immunotherapy. You have to use methylprednisolone initially high doses and then you have to taper. Coming on to neurocysticercosis, yes, is recommended with antiparasitics. It reduces the seizure and inflammation. It is included with the part of the therapy. In brain abscess, if the patient is having cerebral edema, then you can use the steroid where it reduces the mass effect in cerebral edema and may impair the antimicrobial penetration. So overall, if you see in infection, that is CNS infections, in Streptococcus pneumonia, in Haemophilus influenza, tubercular meningitis is what we commonly see in our ICUs, whereas it is not useful in Listeria and cryptococcal, but in autoimmune and neurocysticercosis, yes, it is indicated. So these are the positive indications for steroids where you have to ignore it in Listeria and cryptococcal meningitis. Coming on to spinal injury. So why do we use steroids in spinal injury? Because of the anti-inflammatory properties, it could reduce the spinal cord edema. And it also has some neuroprotective effects like improvement of vascular perfusion, prevention of calcium influx, modulation of the inflammatory cells. It prevents the neurofilament loss and inhibition of lipid peroxidation and inflammatory cytokines. So the commonest agent used is methylprednisolone. So what does the evidence say? So earlier there was NASIS 1 trial where they compared low dose steroids with high dose methylprednisolone within 48 hours of spinal cord injury, where they found no difference in neurological improvement but higher complications with the methylprednisolone group. Then came NASIS 2 trial where they compared the methylprednisolone with naloxone, where they found that significant motor and sensory recovery with methylprednisolone within 8 hours of spinal cord injury, but there are always obviously increased complications. Then came NASA's tree trial, where they compared 24 hours versus 48 hours methylprednisolone and trilazad mesylate, which is an antioxidant, within 3 hours of spinal cord injury, where they found that no difference in outcome for treatment initiated within 3 hours. So overall, coming on to guidelines, in 2013, the American CNS joint guidelines recommended against the use of spinal cord injury, and European and Polish guidelines also refused the use of methylprednisolone. And there was in 2017 where AOS spine guidelines suggested the use of 24-hour high-dose methylprednisolone within 8 hours of spinal cord injury. But the recent meta-analysis in 2020 confirmed no neurological improvement with high-dose methylprednisolone. So overall, we are not using the methylprednisolone because there is no improvement, there is only eye complication. So this evidence remembrance may be important because this NASA's and all is named a trial. Maybe if you could just remember, that is why I just put it in a table form. So you can just write one line if it is asked for evidence. So coming on to brain edema, when it comes to ICH, yes, it's a no-no. It is not recommended for ICH. I think when we discussed ICH also, no steroid for ICH. When it came to crash trial in traumatic brain injury, there is even many trials after crash, there is no mortality benefit. There is only increased mortality with high-dose corticosteroids, so we are not using it. So ICH and trauma, there is no. Coming on to vasogenic edema, when the patient is having a malignancy because of a tumor or an inflammatory condition, like I told you, in brain abscess or a cysticercosis, or there is some inflammation which is causing brain edema, then you can use it for vasogenic edema. So the corticosteroids, generally they stabilize the blood-brain barrier, they reduce the vascular permeability and suppress the inflammatory cytokine, alleviating the vasogenic edema. So if it is for the intent of vasogenic edema, the preferred agent is dexamethasone, where you can use 4 to 10 mg IV or orally every 6th hourly, and based on the clinical response, you can taper to stop the rebound edema or the effects. Okay. And there was a Cochrane review in 2005 where it compared the use of steroids in many different conditions, where they found that the efficacy of corticosteroids in vasogenic edema is good, where there is improvement in the clinical outcome. Coming on to the other uses, of course, in anaphylaxis. So when you see the pathophysiology of anaphylaxis, you can see that the effect of the glucocorticoids can happen early as well as late. Okay, so rapid effects, that is the non-genomic effects, which happens within 5 to 30 minutes, where it could inhibit the mast cell degranulation and increase the production of the anti-inflammatory mediators. That could be the use in early. In late, that is with the gene modulatory effect, where it could take up to 2 hours to reach the maximal effect, where it reduces the number of active mast cells and it suppresses the production of pro-inflammatory molecules by down-regulating the gene transcription. So the use of the corticosteroids can happen at non-genomic way in the earlier times, and in the later effect it could cause suppression of the pro-inflammatory cytokines by down-regulating the gene transcription. But when we come to guideline, the American guideline is against using corticosteroids because they feel that there is no role in the earlier stages, where epinephrine is considered to be the first line therapy. Glucocorticoid is suggested as second or third line therapy in Australian and other guidelines, but not in American guidelines. In Australian Canadian guidelines, they say that glucocorticoid is a second or third line therapy, but in American guidelines, they don't say that. It may reduce the hospital stay length, but it does not significantly affect the revisit rates. But effect on preventing the biphasic reactions, like that is the thought put into our brain, like since MBBS times, yeah, it prevents the biphasic reactions. But when I went through many review articles, the outcome with biphasic reactions are also inconsistent. Like many studies say there is no effect on biphasic reactions. So many studies have to be done to prove this efficacy of steroid for the biphasic reactions and the delayed prevention. So overall, the conclusion is epinephrine is the first line. Glucocorticoid can be suggested as second line, third line therapy according to Australian and Canadian guidelines, but American says no. It may reduce the length of the stay, but the revisit rates and the biphasic reactions is still controversial. Coming on to use in thyroid storm, I think ma'am just finished this. So of course it reduces the conversion of T4 to T3. So thyrotoxicosis is always associated with subtle impairment of adrenocortical reserve, and the dose suggested as per guidelines is hydrocortisone 100 mg every 6 to 8 hourly or dexamethasone 2 mg IV every 6 hourly, continued until the resolution of the thyroid storm. So there was an analysis of nationwide administrative database which indicates administration of glucocorticoids did not improve the survival in patients with thyroid storm. So overall the study says there is no benefit, but still we use it for thyroid storm. Myxedema. In all myxedema cases, there is a possibility of secondary hypothyroidism and hypopituitarism. That is why we use hydrocortisone. So we have to use hydrocortisone until adrenal insufficiency is excluded. So intravenous hydrocortisone should be given at a dose of 100 mg every 8 hourly. Not treating the adrenal insufficiency with hydrocortisone may precipitate adrenal crisis in such situations. So you can send a random cortisol before starting the therapy, and you can see the hydrocortisone, steroid levels, and then you can taper. It can also be stopped without tapering. Coming on to lupus nephritis. So when it comes to lupus nephritis, it suppresses the clinical expression of the disease and improves survival and prognosis. Of course, we know in all the autoimmune conditions, steroid stands the first line of immunotherapy. So not only in lupus nephritis, any complications related to lupus, like even if it comes to pneumonitis, polyserositis, vasculitis, thrombocytopenia, CNS disease, any such conditions, steroid is the first line therapy. In cases of active nephritis, you have to use IV methylprednisolone as a pulse dose for life and organ threatening disease, that is 1 gram per day for 3 days, monthly for 6 months, with 0.5 mg to 1.5 mg of oral prednisolone per kilogram between the pulses to control both the renal and extrarenal manifestations. In severe lupus nephritis, high dose steroids can be used for controlling the inflammation. Coming on to brain death, where just sir discussed this, there could be pituitary deficiency leading to hemodynamic instability. So steroid may reduce the inflammation, thereby improving the graft organ functionality also, where we use methylprednisolone 15 mg per kg immediately after the diagnosis of brain death and every 24 hours afterwards. Alternatively, you can use 250 mg followed by 100 mg per hour infusion also until organ retrieval. Okay. So this completes the use of steroid in critical care. If there is any doubt, please put it in the message. I will respond. So let us go to the next topic, that is adrenal insufficiency. So I had tried to put as many tables and made the most of the review articles findings as simple as possible. Though even though I try to minimize the content, but it is so much only. So I would just suggest you to just go through one more time and just keep the key points as tables, so which you can represent in the paper. The more pictorial and table wise it is, the more marks you are gonna get. Just 1 minute. Slideshow. So coming on to the next topic, that is adrenal insufficiency. Let us briefly see about the adrenal insufficiency, what are all the types, and then if we go to SERSI, we will understand what is relative adrenal insufficiency. So what is adrenal insufficiency? It is nothing but complete or partial cessation of adrenal steroidogenesis. So when it comes to adrenal insufficiency, there are 3 types. One is primary adrenal insufficiency, that is any problems with the adrenal gland. A secondary adrenal insufficiency, that is any problem with the pituitary gland. Tertiary adrenal insufficiency, which is nothing but any problems with the hypothalamus. So when it is a primary adrenal insufficiency, that is problems with the adrenal, just now we saw the physiology, right? The corticotropin releasing hormone, the ACTH will be high or normal to high because it is trying to compensate for the low steroid. But when the adrenal gland is not producing the cortisol, obviously there will be low cortisol. Coming on to secondary, when there is a problem with the pituitary, there will be low ACTH and low cortisol, but the corticotropin releasing hormone will be high. When it comes to tertiary adrenal insufficiency, that is any problems with the hypothalamus, the corticotropin releasing hormone will be low. The other two will be low because the primary signal only is low. So this is again a table depicting the gist of primary, secondary, tertiary adrenal insufficiency. I told you primary is because of the adrenal. Any problems with the adrenal like autoimmune, hemorrhage, metastasis, or drugs affecting the adrenal glands, where the patient can have severe cortisol deficiency. In secondary adrenal, if there is any problem with the pituitary, like tumors, hypophysitis, infiltrative diseases, traumatic brain injury, or any drugs causing secondary hypopituitarism, can have severe ACTH deficiency. And tertiary, it is because of the prolonged use of supraphysiological doses of exogenous steroids, causing constant HPA axis suppression, causing low CRH, is the primary causes for the primary adrenal and tertiary adrenal insufficiency. Coming on to symptoms, the patient can have overall the same symptoms because steroid is low. So they can have fatigue, weight loss, nausea, vomiting, salt craving, postural hypotension, hyperpigmentation, hypoglycemia, and hair loss. But when it comes to adrenal crisis, it will be more common with primary adrenal insufficiency because the adrenal gland is not responding to whatever ACTH and CRH is signaling. So obviously they are more prone for landing up in adrenal crisis, requiring steroids immediately, having refractory hypotension in cases of acute crisis, whereas the other two can still tolerate whenever there is a crisis. So the triggers in primary adrenal insufficiency for adrenal crisis could be infections, trauma, hemorrhage, and some of the medications. When it comes to secondary, it could be surgery, illness, injury causing stress on already compromised pituitary. When it comes to tertiary, it could be withdrawal of the exogenous steroids or injury to the hypothalamus. So the management is overall replacing the therapy, but when it comes to adrenal crisis in primary, you have to be very aggressive. Along with steroid fluid and vasopressor, steroid supplementation plays a primary role. So how are we going to investigate? As I told you, you have to look for CRH, ACTH, and cortisol levels, and aldosterone levels, obviously. So in primary adrenal insufficiency, the morning cortisol level will be less than 140 nanomoles per liter with elevated plasma ACTH, followed by the synchrotron stimulation test, which we will discuss later. In ACTH measurement, the ACTH value will be more than 66 picomole per liter, suggest PAI. Mineralocorticoid deficiency confirmation, where in primary the mineralocorticoid will be low, where in other two it could be normal. In secondary, that is in pituitary abnormalities, you can check for insulin tolerant test, which is the gold standard test for pituitary hypopituitarism. So this is with respect to primary, secondary, and tertiary. So let us discuss which is important to us, that is SERSI. So SERSI is defined as an inadequate cellular corticosteroid activity for the severity of the patient's illness manifested by insufficient glucocorticoid receptor mediated downregulation of pro-inflammatory transcription factors. Okay, this is the definition at the molecular level. So the simple definition is the patient is in stress. The body ideally has to give up more steroids to fight the stress, which is not happening. So where it could be seen in acute conditions like sepsis and septic shock, and in severe community acquired pneumonia, ARDS, cardiac arrest, head injury, trauma, burns, and post-major surgery. So these are all the scenarios where you can see patient having early SERSI or late SERSI. So the incidence in critical ill with SERSI is approximately 0 to 30%. But when it comes to septic shock patients, it is around 25 to 40%. And in trauma patients, it is around 50 to 70%. So coming on to pathophysiology. So whenever a stress happens, so the initial response of the HPA axis is to stimulate, produce more CRH, to stimulate more ACTH, and then produce more cortisol to fight the initial stress. So in the acute phase, there will be increased ACTH, increased cortisol synthesis. Whereas when it goes to chronic inflammatory phase, the production of the ACTH could be impaired. I will tell you why the production could be impaired. And there could be less response from the higher signals itself, the hypothalamus pituitary axis itself. So when you see this picture, there could be acute inflammatory phase, followed by there could be a early SERC because of cytokine induced HPA axis dysregulation or direct impairment of the adrenal cortisol synthesis by the cytokines, where there could be altered cortisol metabolism, where there could be tissue resistance to cortisol. All these inflammatory cytokines can suppress the adrenal outcome, causing early SERC. Or there could be late SERC, wherein there is exhaustion of the HPA axis. There is persistent feedback inhibition from the elevated cortisol level, which I will explain in the next slide, where there could be adrenal atrophy or damage, where there is prolonged altered cortisol metabolism because of the reduced clearance, because of the organ dysfunction causing HPA axis suppression, and sustained tissue resistance to cortisol. So whenever an acute inflammation happens, there could be acute inflammatory phase where there could be acute elevation of ACTH and increased cortisol synthesis. Followed by, there could be early SERC if suppose there is an hyperinflammatory phase causing cytokine induced, tissue resistance induced, cortisol production induced suppression of the adrenal gland and the HPA axis, where there could be early SERC, and late SERC, when the pathophysiology continues for a long time, there could be late SERC. So as I told you, the three highlight pathophysiology mechanisms in SERC is three. One is impaired functioning of the HPA axis. There is altered cortisol metabolism, where there is tissue corticoid resistance. So this three lines should come to your mind whenever there is SERC pathophysiology. So let us see individually one by one. So whenever there is a critical illness, we know that there is temporary ACTH increase, where when during the first week of illness, there could be a low ACTH because of whatever pathophysiological mechanisms I told you, like the cytokine can cause adrenal suppression, or because of the low cortisol binding protein and low albumin, there could be free cortisol in the circulation, giving a signal that cortisol is more, so you don't produce more, causing low ACTH. Okay, because of many such reasons, there could be low ACTH during the first week of illness. And when the patient is staying for more than 4 weeks, there could be furthermore dysregulation with the ACTH, causing dysregulated HPA axis, causing mitochondrial dysfunction and energy and metabolic disturbances, and finally inadequate or detrimental stress response. Coming on to the altered cortisol metabolism and the negative feedback in critical illness. Actually, this plays the primary role for HPA axis suppression as well as the tissue resistance. So, the regulation of the cortisol production during a critical illness is complex, and it involves intricate interactions among the CRH and ACTH pathways, autonomic nervous system, vasopressin system, and immune system. So there is a disruption of the normal circadian rhythm of cortisol secretion due to the rapid increase of the ACTH release because of the acute critical illness. So initially there is a reduced cortisol breakdown in the liver and the kidneys during the critical illness. This is due to the suppressed expression and activity of the cortisol metabolizing enzymes with an extension of cortisol half-life and hypercortisolemia. So this is one reason for the hypercortisolemia whenever there is an acute stress. Additionally, the cortisol is released from the plasma binding proteins transcortin and albumin due to the decreased hepatic synthesis of and decreased cortisol binding to these proteins. So usually the cortisol is bound to CBG and albumin. So when these proteins are also produced because of the reduced because of the hepatic dysfunction or because of the inflammation, then cortisol may not bind to these proteins also, and there may be free cortisol in the circulation, which may lead to hypercortisolemia. So overall, there is disrupted CRH and ACTH pathway. So there is reduced cortisol breakdown in the liver and the kidneys, leading to prolonged cortisol half-life. And there is decreased cortisol binding because of the reduced CBG albumin, causing increased free cortisol availability, which overall signals that there is hypercortisolemia. So this will give a negative feedback to the pituitary, causing impaired POMC processing, that is pro-opio melanocortin into ACTH, impaired POMC processing, and decreased mature ATCH secretion, overall leading to altered cortisol regulation and dysregulated cortisol homeostasis and detrimental response to the stress. So this is the major pathway where the brain thinks there is hypercortisol in the circulation, causing altered CRH and ACTH pathways, causing the first mechanism also which I explained you, causing overall confused response to the stress. And the third mechanism is that tissue resistance and corticosteroid resistance in SERC. So generally there are two corticosteroid receptors. Okay, one is GR alpha and one is GR beta. So what does alpha do? The GR alpha binds to glucocorticoids, that is like cortisol. Once activated, once bound and activated, it helps to regulate the genes that reduce the inflammation and manage the stress response. That is the function of GR alpha. What does GR beta do? It is a variant of the glucocorticoid receptor that does not bind glucocorticoid, but instead it competes with the GR alpha receptor for binding to the DNA or other cellular components, effectively blocking the GR alpha doing its job. So GR alpha is the one which produces a positive response with the steroid binding. GR beta is the one which is going to compete with the GR alpha and prevents its action. Okay, so what happens in SERC or any critical illness? There is transient GR beta increase and there is dominant negative role of the GR beta. That means it gets interfering with the GR alpha activity. So what happens? There is serum induced glucocorticoid resistance. There is imbalance between GR alpha, GR beta levels, overall leading to mitochondrial 124 expression, and there is downregulation of the GR alpha, leading to steroid therapy induced resistance. Sometimes steroid therapy itself can reduce, steroid therapy itself can induce resistance to the SERC patients. So overall there is GR beta level increase. The steroid, giving a steroid as per the studies, given the steroids itself can induce resistance. And there is also a mitochondrial receptor 124 expression which reduces the GR alpha activity. All these three mechanisms can induce tissue level corticosteroid resistance in SERC. So first there is hypercortisolemia, which is causing the HPA axis suppression and leading to HPA axis dysregulation. And there is tissue resistance and corticosteroid resistance happening in SERC because of receptor level imbalance and other factors like mitochondrial factors and steroid therapy itself inducing resistance, causing tissue resistance. And final mechanism in SERC is that drug-induced SERC pathophysiology. So certain medications administered during critical illness can induce the resistance at the levels, like administration of exogenous glucocorticoids and other drugs like opioids, azole antifungals like ketoconazole, and psychoactive substances can cause these actions. So when you abruptly withdraw the glucocorticoid therapy, it may precipitate the symptoms of adrenal insufficiency. Opioids also induced adrenal insufficiency in a similar way like steroids, inhibiting the HPA axis at the level of hypothalamus, decreasing the cortisol production. Benzodiazepines contribute to the rapid decline of cortisol production by inhibiting the functions across central and peripheral points of the HPA axis. And ketoconazole also acts in the same way. Etomidate also acts in the same way. So drug-induced SERC, because of various drugs like glucocorticoids, opioids, benzodiazepines, azole antifungals, etomidate can cause suppressed CRH and ACTH synthesis, causing adrenal cortex atrophy, finally leading to adrenal insufficiency. This is one of the additional pathway along with the SERC pathophysiology pathway. So this is a picture depicting all four mechanisms. So whenever there is acute critical illness, there is dysregulation with the HPA axis in the early SERSI period and also in the late SERSI period because of the sustaining inflammatory process leading to insufficient response. And in the initial phases, there is receptor imbalance and there is mitochondrial factor stimulation leading to tissue resistance at the of the corticosteroids. And there is also hepatic and renal dysfunction or the corticosteroid binding protein or albumin dysfunctions causing hypercortisolemia, signaling the HPA axis that there is hypercortisolemia and poor ACTH response. And finally, drugs additionally causing SERSI, adding to the additional SERSI pathophysiology. Coming on to clinical features. So the clinical features in ICU, it will be refractory hypovolemic shock, where the patient can have coma, encephalopathy, poor neurological recovery after sedation cessation, and persistent vasopressor need. The simple symptoms which we discussed before, there could be fatigue, weight loss, syncope, fever, confusion, somnolence, leg cramps, postural dizziness, hypotension in stable patients. Whereas when it comes to severe, the one sign we would have is refractory hypovolemic shock, refractory shock, and central symptoms like coma, encephalopathy will be the primary symptoms. And associated findings will be reduction in the adrenal gland volume when you do an imaging, and elevated inflammatory markers like cytokines when it is because of the initial critical illness. So this picture depicts the system-wise and laboratory-wise clinical features of SERSI. Neuropsychiatric, there could be confusion, delirium and coma. General, there could be fever, weakness and increased fatigue. Cardiovascular, there could be tachycardia, hypotension resistant to fluid therapy because of the decreased catecholamine sensitivity, and there is elevated cardiac index. When it comes to GIT, there could be decreased appetite, nausea, vomiting and abdominal pain. When it comes to musculoskeletal, patient can have muscle and joint pain. And laboratory finding could be hypoglycemia, hyponatremia, hyperkalemia, hypercalcemia, metabolic alkalosis, new onset eosinophilia, persistent high inflammatory markers non-responsive to empiric antibiotic therapy. Diagnostic imaging, when you do an CT scan, you may find hemorrhage or necrosis in the hypothalamus, pituitary or the adrenal gland. So coming on to diagnosis. So I would, so laboratory you first see where there is hyponatremia, there could be elevated creatinine, there could be normochromic anemia, lymphocytosis, eosinophilia, hypoglycemia, hypercalcemia, low albumin, low cortisol binding levels, and high bile acid and bilirubin levels because CBG is low, and normal or low ACTH levels. So when it comes to synactin test, various guidelines and various society recommendations keeps varying. When it is adrenal insufficiency, yes, you have to do the synactin test. But when it comes to SERSI, there is no strong recommendation for the synactin test. So when we see 2008 SCCM guidelines, random plasma or serum total cortisol level less than 10 microgram per deciliter, or change in, that is the delta cortisol level less than 9 microgram per deciliter at 60 minutes with ACTH stimulation test diagnose SERSI diagnosis. But in 2017 SCCM guidelines, they said that there is no indication for ACTH stimulation test. You just clinically diagnose, and if you can do this total cortisol, you do, but there is no indication for ACTH stimulation test. But Endocrine Society recommends you do ACTH stimulation test if there is a primary adrenal insufficiency and there is an adrenal crisis. And there was also a debate between a low dose versus a high dose syntropin test, which is not recommended by SCCM guidelines. Even various studies says that there is no clinical outcome benefit when you do low or high dose ACTH test. So overall, the recent SCCM guideline says there is no need to subject the patient to synactin test when you suspect a SERSI. You can directly administer the steroid. If you could do total cortisol, it will be better, random cortisol or total cortisol. So what all we could measure in SERSI? Number one, free cortisol you can measure, which is the biologically active cortisol. You need to have specialized techniques like mass spectrometry or an equilibrium dialysis, where low level indicate biological activity of the cortisol. Coming on to total cortisol, where it measures both free and bound cortisol. According to SCCM, they prefer total cortisol, less than 10 microgram, suggests CERSI. Then we can measure cortisol blinding globulin, which could be low in acute sepsis or critical illnesses, where it assesses the changes in cortisol transport. Then we can do an ACTH stimulation test, which we will see now. In delta cortisol also we will see now. Then we can also assess cortisol binding capacity, where cortisol binding is saturated when the cortisol is at the level of 22 to 25 milligram per deciliter. So increased free cortisol and decreased illness due to reduced CBG glycosylation and cytokine effects may show that the saturation is already done. Free cortisol is more. Salivary cortisol can also be used, but it is not recommended by any of the guidelines. We can also use cortisol distribution volume, which is increased in critical illness due to the decreased synthesis of the binding proteins, so which may not give us a better clue in critical illness. So overall in critical illness, you can measure free cortisol, total cortisol, and you can do a ACTH stimulation test. So free cortisol requires specialized techniques which may not be available in some of the labs, but total cortisol is suggested by SCCM guidelines, which you can use. And ACTH stimulation test, if suppose it is an adrenal crisis because of a primary insufficiency, you can try, but SCCM guidelines is no need of any ACTH stimulation test. So what is ACTH stimulation test? So are basically stimulating the central so that it can signal to the periphery to stimulate the cortisol or not. That is the simple definition. So you administer a supraphysiological dose of ACTH. So normally I told you during a stress response there will be 25 to 40 microgram per deciliter. So here you are giving a 250 microgram of ACTH to stimulate the production of the cortisol. Where once you administer, you are going to measure, before administering, you are going to measure a baseline serum cortisol level, and after administering, you are going to measure the total cortisol level. So if the total cortisol level is more than 18 microgram per deciliter, then it rules out the diagnosis. So you are going to also check the response at 30 and 60 minutes post administration. As I told you, if the response is more than 18 microgram per deciliter, you are ruling out. But if the response is less than 80 microgram per deciliter, then it may indicate CERSI at 30 minutes and 60 minutes. So this was one flow chart from one of the review article, which was good to understand. Like whenever you are suspecting a CERSI, you are going to check the total cortisol level as suggested by the guideline. If it is less than 10, then the suspicion of CERSI comes, and you are going to stimulate with the ACTH stimulation test. If it is less than 10, it confirms the diagnosis of CERSI, so you are going to supplement with steroids. If it is more than 10, then you stimulate with ACTH stimulation test at 30 and 60 minutes. And if you see the delta cortisol level, that is before and after ACTH is level is less than 9 microgram per deciliter, then it is indicative of CERSI. If it is more than 9 microgram per deciliter, then it is no CERSI. So usually when it is more than 10, if still the patient is having clinically low, hypovolemia, refractory hypotension or encephalopathy, that is when the persistent suspicion of CERSI will be there. So in such scenarios, you can subject the patient to ACTH stimulation test and see the delta cortisol level, and you can diagnose CERSI. So what are all the limitations to this ACTH test? Why the SCCM guidelines recently told no? Maybe this could be the reasons. One is results can be affected by chronic illness, critical illness, medications that interfere with the cortisol metabolism. So there may be false positive or false negative results. And we are giving a supraphysiological level, that is 250 microgram, where the normal stress response is only 25 to 45 microgram. So whenever a patient is having a relative adrenal insufficiency, when you give a 250 microgram, there are chances that there could be a positive response, right? So which could be a confounder to the final result. And altered physiology in critical illness, like whenever there is a low CBG, low albumin, then the cortisol levels could be normally high in the plasma or the serum, which could affect the result value. And if the patient is on long-term glucocorticoid therapy, then overall the HPA suppression could happen. So it may confound the outcome of the result. And as I told you, some of the drugs like opioid, ketoconazole, etomidate can alter the HPA axis, which could confound the test result. So these are all some of the limitations of the synactin test, maybe because of which it may not be useful when we are thinking in terms of acute critical illness not responding to the initial therapy. So how are we going to manage CIRSE? If it is we know that if it is a patient with primary or secondary adrenal insufficiency landing up in adrenal crisis, we'll have a strong history that the patient is having been on steroids and they suddenly withdrew it, or there is an acute illness which is complicating the issue. In such adrenal crisis, you are going to initially administer the hydrocortisone and taper as per their previous doses and adjustments, clinical response. But when it comes to CIRSE, if it is an early CIRSE, like there is an initial acute increase in the ACTH and later there is, because of the hypercytokainemia, there is early CIRSE, the patient is not responding to fluid therapy, vasopressor therapy, and early empirical antibiotic therapy, landing up in refractory shock, you are not subjecting that patient to syncopin stimulation test. You are going to use the sepsis guideline steroid therapy, that is 200 mg IV 24th hourly. And then see the response, continue for 5 to 7 days and see the response. If the response is good, you can immediately stop. There is no tapering doses needed, which we just discussed some time before. But if the patient is staying in the ICU for like 3 to 4 weeks and the patient is constantly, maybe in such scenario doesn't happen, but if the patient is having myopathy, encephalopathy, or requiring a low dose vasopressor for maintaining the BP and landing up in late CIRSE, the actual critical illness corticosteroid insufficiency, then you can subject the patient to ACTH stimulation test if needed. Then you can consider giving steroids in a different dose as suggested by the guidelines. Like consider hydrocortisone 60 mg IV 24th hourly as a bolus of 40 mg IV morning plus 20 mg IV evening. This is for the circadian rhythm. If the patient is stable and other manifestations of corticosteroid insufficiency is seen and the patient is there for a long time, then you can use such a dose and slowly taper the dose as per the clinical improvement. But in acute early CIRSE, we are not doing this. We are giving 200 mg 24th hourly as per the guideline. But if it is a patient on chronic ICU stay and with symptoms of chronic corticosteroid deficiency landing up in CIRSE, then you may match the circadian rhythm and supplement the dose. And there is also other method. So if suppose it is a septic shock not responding to therapy, you are giving 200 mg per day for 5 to 7 days. But if you have some strong underlying disease, like we saw so many doses in so many conditions, right? So if suppose it is a CIRSE in early moderate to severe ARDS, then you can use IV methylprednisolone 1 mg kg per day. If it is a CIRSE in severe community acquired pneumonia, then you can use IV hydrocortisone less than 400 mg per day for 5 to 7 days. But if it is a patient, as I told you, long-standing, having manifestations of CIRSE, then you can match the diurnal variation and give 60-40 in the day and night as per circadian rhythm matching. So this completes our CIRSE topic. So I had taken material from so many review articles and guidelines and I made it into gist. If you read this, it is more than enough. So this completes our today's topic. If any doubts, please put it in the WhatsApp group. Definitely we'll share the answers. Thank you.